Good morning. Welcome back. I hope you had a nice rest. Again, we apologize for the not so good weather today here in Athens, but that's life. Normally, it's not like that in the middle of May, almost. I would also like to express our gratitude for joining us yesterday at the dinner. I hope you enjoyed and you had the opportunity to network a bit more. It's really about establishing and nurturing these networks. So thank you very much for taking your time. We are very excited about the program today as well. We think we have very nice program to offer you and that can foster important discussions and maybe help us consolidate a plan for the future on how we are going to work together and our priorities. And with that, we did a summary already yesterday, so I'm not going to go into wrap-ups or catching up with what we already said. We will include it in the minutes and we will prepare a report of the meeting. And we will have also an evaluation. So at the end of the day, we will share with you a link. So we would like you to fill an evaluation of the meeting and the preparations leading to the meeting, which you can fill in maybe next week. It doesn't need to be filled today. It will be done online. And with that, we plan to eventually finish sharp according to the timeline, or eventually even a little bit earlier, if some of you still have the opportunity to go around and see a little bit of Athens. We'll do that if we can. So in that case, allow me to hand over the floor to my dear colleague, Dr. Mafaten Chaouli. She is going to present on the status of patient safety in the WHO European region, mostly focusing on the findings from the global survey. You've seen that Dr. Nilam yesterday presented some very interesting global findings, and today we will go a bit more in depth in looking at our own results in the European region. We believe it's very important. We will have a discussion, and then we will have also a short contribution presentation from the Honorable Delegate of Germany. So Mafaten, over to you. Thank you.
Okay, no problem. Perfect. So, good morning, everyone. Esteemed colleagues, distinguished members of the European Network for Quality of Care and for Patient Safety. It is both an honor and pleasure for me to stand before you today and to discuss one topic that is of great importance, not only to healthcare systems, but also to the very essence of our mission as healthcare professionals, patient safety in the European region. Our region consists of 53 diverse countries with different cultures, languages, and health systems. Even within one country, levels of patient safety can vary significantly from regions and from healthcare facilities. And even within one healthcare facility or organization, we can have different levels of patient safety in different departments and units. And this is due in part to the kind of culture that is in those units and divisions or departments. As you know, we have many kinds of cultures. We have the culture of patient safety, safety improvement. We have the culture of excellence, culture of continuous improvement, culture of risk management. So all these cultures can be different and they influence the level of patient safety that we are talking about. So, yep. As we navigate through the complexity of each individual health system, we must not lose sight of the common goal that united us all, which is do not harm. While some countries within our region have advanced healthcare systems with well-established patient safety practices, others are still in the process of developing and implementing such good practices. And this disparity highlights the need for continuous improvement, the need for exchange of knowledge, and the need for collaboration across borders. In this session, we will explore together the current state of patient safety across our region through few indicators that were explored by the global survey on the implementation of the Global Patient Safety Action Plan, and that was conducted recently by the headquarters. So it is essential to acknowledge the critical role of the Global Patient Safety Action Plan in shaping our approach to improving patient safety in our region, with a vision to create a world in which no one is harmed in healthcare and every person receives safe and respectful care every time, everywhere. The Global Patient Safety Action Plan is a driving force in our collective efforts to eliminate avoidable harm in healthcare in our region. A part of our commitment to the Global Patient Safety Action Plan implementation, we have been mandated by the World Health Assembly to report on its implementation across the European region every 2 years until 2031. So in order to facilitate this reporting and assess the progress made by member states, a survey has been conducted by the WHO headquarters, which will allow us to, at the same time, to work on our roadmap for implementation of activities to improve patient safety across our region. So as you all know, the Global Patient Safety Action Plan outlines 7 strategic objectives that guide our efforts in improving patient safety. These objectives serve as the foundation for our shared vision of a safer healthcare environment. We have make zero avoidable harm a priority, build reliable health systems, ensure safety in clinical processes, engage and empower patients and families, support health workers in providing safe care, share information and knowledge, foster multicultural and multinational collaboration. As we continue with our presentation, I will discuss the implementation of these strategic objectives in the European region and examine a sample of indicators for each of the strategic objectives. So, out of the 53 member states in our region, 32 countries have responded to the survey, providing valuable insight into their patient safety practices. Of course, this can be improved as the survey platform is still open, and we encourage member states to submit their data because, as you will see later on, it is very important and it influences our roadmap for action to improve patient safety. Yeah. So in this slide, I'm sharing with you the indicators that the headquarters will be using to monitor progress globally. The ones that I highlighted in yellow represent the indicators that we are planning to include in our regional status report for quality of care and patient safety. So I will present these indicators and would like to have also your feedback on whether you agree or on them or have any other suggestions. So the first strategic objective, one of the key indicators for measuring progress towards the implementation of the first strategic objective of the Global Patient Safety Action Plan, making zero harm, avoidable harm a priority, is the number of countries that have developed a national patient safety action plan. So as you can see, out of the 32 European countries that responded to the survey, only 11 countries fully met the criteria, which makes around 34%. So while this highlights the progress made by some countries, it also underscores the need for improvement across our region. Our goal is to increase this percentage to 100% by 2030. So, for example, we could aim to improve this percentage by at least 5% annually. For strategic objective 2, building reliable health systems, we focused on the indicator, the number of countries that have a reporting system for never events in place. Never events, as you all know, are serious, preventable patient safety incidents that should not occur if proper safety precautions are implemented and followed. So out of the 32 respondents, only 13 countries fully met the criteria, which is about 13%. So our aim is also to reach the 100% implementation. And to achieve this goal, we need to increase the number of countries with the reporting system for never events by approximately 2 countries per year. For strategic objective 3, we focused on 3 indicators. The first indicator is the number of countries that have a national program for infection prevention and control established. The results show that 22 out of 32 respondent countries have such program in place. And to reach our goal of 100% implementation by 2030, we need to assist the remaining 10 countries in establishing their own national infection prevention and control programs. As you know, healthcare-associated infections represent a significant patient safety issue in the European region. And as reported by the European CDC, 1 in 15 hospitalized patients in the region experience a healthcare-associated infection. Well, in this slide, that I consider linked to healthcare-associated infections, this slide reflects the prevalence of use of antibiotics in acute care hospitals, which can be linked to healthcare-associated infections or sometimes linked to misuse or overuse of antibiotics. So we can see the high level of variation between countries and a significant opportunity for improvement as well. The second indicator for strategic objective 3 is whether a country has defined an indicator for medication-related harm. And yesterday we saw that this area is of great importance to member states. And out of the 23 responding countries, only 7 countries answered yes to having defined an indicator for medication-related harm. So our goal is also to get to the 100% implementation and have countries define an indicator to measure this harm related to medication use and by 2030. And we need to focus on assisting at least 2 countries per year in this. As you know, medication-related harm is a crucial aspect of patient safety, as it can lead to increased morbidity, increased mortality, and healthcare costs. In our published fact sheet on medication errors in Europe, that we released last year during the World Patient Safety Day, we highlighted some alarming statistics that underscore the importance of addressing this issue. And as you can see, the numbers are very high. The estimated annual cost of medication errors in Europe can reach 21 billion euro. And 50 to 70% of these errors, the evidence show that we can prevent them through comprehensive systematic approach to patient safety. The third indicator for the implementation of the third strategic objective of the Global Patient Safety Action Plan in our region is the number or the extent to which patient safety system interventions have been extended to include primary care services. Primary health care is a vital component of the healthcare system, and incorporating patient safety measures in this area is essential for ensuring safer care across the continuum of care. So among the 32 responding countries, only 5 countries fully met the criteria for extending patient safety system interventions to primary care services, while 22 countries partially met the criteria, and this demonstrates that there has been some progress made in this area. But there is still significant room for improvement, and we can help bridge the gap and ensure primary care services are included in these countries' patient safety efforts. For strategic objective 4, we have 2 indicators. The first one is having patient representatives as part of the governing board of hospitals. And the second is to have patient-reported outcomes and experience reported. And we think that with the theme of the World Patient Safety Day this year, that is focused on patient, involving patient and families in their care and in governance at very different levels of the healthcare system, we can work together in improving this area. The fifth strategic objective, which focuses on inspiring, educating, skilling, and protecting health workers, we focused on the indicators whether the government had endorsed and signed the WHO Charter on Health Worker Safety, a priority for patient safety. Out of the 32 responding countries, only 3 countries have endorsed and signed the WHO Charter. And this indicates that there is significant work to be done in promoting the health worker safety as critical aspect of patient safety across the European region. As you know, patient safety is not about patient only, it's about patients, their families, visitors, and it's about healthcare workers' safety as well. And talking about healthcare workers' safety, I am delighted to announce the development of a course and training materials for healthcare workers in the European region to strengthen their resilience skills during public health crises. This course was developed in collaboration with Leuven University and will help in developing the ability of healthcare workers to cope with challenging conditions during crises. The course includes 4 sessions, as you can see in this slide, and we encourage you, if you want, to take part of the testing or piloting stage of this course, as we will start with Greece and some healthcare workers before launching it officially. All right, so back to our indicators, and for strategic Objective 6, an annual report on patient safety performance is published every year. And this is also low in implementation, as you can see in the slide, as well as for the strategic objective 7, with the indicator on initiatives to engage the private sector and industry in synergetic action for promoting patient safety. So as I conclude this presentation and will give the floor to Joao, we have, probably three key messages to share with you and can be retained from this, these data that I shared with you. So as we come to the first key message is, despite the progress in some areas, there is a significant disparity in patient safety practices across the European region, highlighting the need for continuous improvement, exchange of knowledge, and collaboration across borders. The second key message is, by tailoring our approach to each country's unique context, we can ensure that the support provided is effective and sustainable. The third key message is, engaging and empowering patients, families, and healthcare workers is crucial for improving patient safety. And by involving all stakeholders in the decision-making process and providing the necessary resources and training, we can foster a culture of safety that encompasses every level of the healthcare system. At the end, I am sharing with you our next steps, which are: 1, to establish our regional priorities, and 2, to develop the European roadmap for improving patient safety. And this may include initiatives as country support, technical assistance, sharing best practices, and facilitating collaboration between countries with advanced systems and those in need for improvement. And for this, I will ask you 2 questions by the end of the day, if we can have your feedback on the first question related to establishing our priorities for work. What are the most crucial patient safety priorities for your country? Even 1 priority or up to 3 priorities, based on the survey results that we shared, and of course, based on your experience. And we will collect the answers from you later on. The second is about exploring collaboration opportunities, and what are the potential opportunities for cross-border collaboration that you see for knowledge exchange or joint initiatives to improve patient safety in the region. So how you can support and learn from each other. We would love to have your insight and your suggestions on this. Thank you so much, and to Joao. And if you have any question.
Thank you very much, dear Mafaten. Before I give you the opportunity to pose questions and raise any issues, considerations, allow me just to express my view on this. Clearly, we're lagging behind, right? I mean, we have 53 member states, only 32 replied to the questionnaire. I know it's very cumbersome, and there's more, yet another questionnaire from WHO, but if you want to have a network, we need to engage in these things. So it's very important that maybe some of your countries didn't reply to this questionnaire and we don't have the information. There's no problem at all, but there's an opportunity for you to be part of this process. So my suggestion would be, when you go back, try to check whether there's been a reply and we are able still to collect this information and include it into the process. And of course, most important than everything, you don't want to have a country profile which is blank on the European status report. So it would be really important now that you are officially made responsible for the area by your countries. So let's work together to see, even if you reply to the questionnaire or not, at least we get the information that's necessary. We include it in our databases, share with HQ as well, and it will go into the status report. I think that's very important. On the progress itself, one can say it's very slow. I mean, we are below the global average, which is a challenge. I mean, I wouldn't expect to see the European region there, but there's only 34% of countries with an action plan. Maybe you could say, but we are doing things. Obviously, I'm sure you are. But the reality is that you don't have a national framework, and you're lagging behind compared to the global WHO results, which is not common. Normally, European region is slightly above, because, I mean, we have a different composition, and our set of countries is quite different. And we all know that. So I think we have a challenge here we should embrace, and we need to resolve it. And therefore, it would be very important to work more together. I think Mafatan posed a very important question for the discussion in the afternoon, and that's my last point, is really on, do we need something which is like a framework? Do you need a roadmap? Do you need an European action plan? Do you need a, something that really, or a framework for action, something that helps you, do this together? Normally, you do this at the level of the governing body, so there could be a resolution, or there could be an action plan, a proposal to the regional committee that then goes and is approved. It takes normally a couple of years to be developed and approved, and is developed by all countries. It doesn't mean that you need it to take action, right? But sometimes it might be important because it gives you political visibility. So just for you to think about it, like we have an European action plan on nutrition, on non-communicable diseases, on alcohol, on AMR, on a few things. Perhaps, quality and patient safety, we have global frameworks, and that's very good, especially on patient safety, but maybe something for you to think about, how you would like to take this process forward, because you are the ones to take that decision, and the Secretariat is here only to follow your instructions. So I think I'd stop here, and maybe we open for some comments, questions. Yes, Kyrgyzstan, please.
Thank you very much. It was very interesting. We started discussing between us, did we get this survey, just to learn where we get information, which country responded not? This is first question. Second question, can we look at the questionnaire? At least the one on the slide was about the questions, and we skip it very quickly. I mean, go through this very quickly, but if we can just have a look at that question, just to get idea. Because for me, it's important to understand how it's adjusted to regional office, to our region. We have to take into account different conditions, different countries. We have to take into account, for example, if we talk about primary health care, I think the most important, you ask a question about what is priority for me, patient safety at primary health care, because it's a front line, it's where the connection of population with health system is actually happening, where the all kind of causes of problem could be generated. And there is no condition like in the hospital, right? You can arrange a very good sterile condition in hospital, but in primary health care, it's open area. So there is a lot of question, but all vaccination, all injection, a lot of stuff is going on the primary health care. I'm just trying to say that primary health care probably, because traditionally we think about patient safety, infection control, and we immediately by default thinking about hospital. But I think we need to start thinking about primary health care. I think this is most important for us. And also the regional specificity, like it's in financial protection. the indicator 382, for example, we have regional because we are taking into account the seasonal heating expenditures, for example. And this is huge also for hospital sector, for primary healthcare. If it's very cold, it's definitely not safety for patient. So this is like very simple question, the heating system, the either any sanitation conditions, okay, there is water, what is it? So the basic questions should be also, I think, include, but this is why I'm asking about the question, what kind of question you have there. That is from my side.
Thank you. Thank you. For the first question, I will let Joa answer it because I don't know if I am allowed to say which countries participated or not. No. So, but we know the number of the participating countries, and the aim of our meeting and is to actually advocate for this survey and this platform. It is very important for us to know what are the priorities of where we can interfere and where we can support, in addition to actually the feedback and your input in that, in deciding what are your priorities, what are actually the indicators that we should focus on. As you said, for you, it's this indicator on primary health care, whether patient safety is there are only 4 countries. That's alarming. I mean, yes, other countries may not have the same priority, but that's why we should also tailor our work and support to the context of each country. I think that our message to you is that we want to take this partnership on taking decisions as well, in putting our priorities together, in putting our roadmap together, in deciding which indicators, indicators, we have a lot of them. And the slide I shared earlier with the highlighted ones, those are the indicators that the headquarter will or adopted to follow up on the implementation progress of the Global Patient Safety Action Plan. So for us, we are still studying, or we want your feedback actually on those indicators for our status report on the quality of care and patient safety.
Thank you. Thank you very much. So really, I mean, we're at the start of the process, right? No blaming game here. It's no problem. We will work with you and we make sure that we get your data in, and that's fine. We collect it. I mean, we should have the focal points before we ask for the question about the European region was lagging behind, because if we would have you as focal points, we would have had the system to follow up closely. So in a way, we started the process in a reverse sense. So that's fine. We will get there. Most of the countries that are in this room and online, they actually have filled the questionnaire. So no need to refer to that. We will follow up with you as we build the progress report. We will be in touch and we'll make sure that we get the data from your countries. And because we have the country profiles, that's exactly the place where you can have a small section where you say, these are our challenges. These are the opportunities that we see. So you have an opportunity to showcase good practices and to be more specific on your own case. So my message would be, if you allow me, let's work together on this to get it right. And I'm sure it's going to be a fantastic progress report. Thank you, Mafadan. Another last question here, maybe. Any other colleague would like to take the floor, just to be sure?
Thank you. A couple of points. Thank you, Mafadan, for elaborating on the regional data. As you would recognize that in the process of development of the Global Patient Safety Action Plan, as a roadmap for 10 years, we went through a 2-year development process. And every member state went through critical comments. We had member states briefing at in Geneva with the missions. So I truly believe that this action plan has got input from all member states and also experts from those member states in the process of development. So once we have something which we agreed, we are in a journey for next 10 years and we are still in the first biennium. So it's extremely important for us to create a very strong foundation. I truly believe that. And this was the first round of survey. There would be 4 more rounds of survey like this, for at least for this action plan. And possibly if we are showing progress but not significant, maybe Assembly also extends the action plan for next couple of years. So we don't know how it develops, but we hope that by the end of 10 years, we will have significant improvements in patient safety globally. Now, having said that, the countries which could not so far provide the information in the survey, please, if you can do that, because we still need a baseline. And the second round of the survey would be sometime next year, because we started this survey in October 22. In 2024, we will start it around, say, September, October again, giving a couple of months, so that we could report to the Assembly in 2025. So if you could provide your baseline now, so that when you provide data next year, there will be, you yourself could see the incremental improvements in patient safety. So the survey is still open, the platform is open, and we would like you to, those who could not respond, please respond to that. And we would be closing for the ones which we have already provided, so that the next time when they provide data, and then we will open it up. So it will be a platform, and we are also going to create a global patient safety platform portal where countries could even see their own data over time. So maybe by the end of this year or early next year, we will have a global patient safety platform where countries could actually see, and also have the platform could generate country profiles as well. So some development work is still going on in that. I think for me, it's very important to learn from how countries actually provided the information. So what were the methodology when you were providing it? For those who have provided the response to the survey, how did you work towards providing this response? Did you create some working groups? How did you get national, the national data, the countrywide data? So if you can share those methodologies, there also will be very good learning process for other countries. And as you're aware, that we had extremely successful Global Ministerial Summit, which was hosted by the Swiss government in February. There were more than 80 high-level delegations from countries who participated. And I think it's an opportunity for us when we have 102 countries responding to the survey and 80 countries and their high-level political leadership providing commitment to the action plan. It's an opportunity for us to harness that. And we at the headquarters level are planning to organize some inter-regional workshops to bring together countries who have already provided the response to the survey, and even the others who have not, and to learn how they actually went around providing the survey, looking into the methodology, and also those who could not respond, what were the challenges they were facing, whether there are any comments on the tool, whether you would like any fine tuning of the tool. We can't change it drastically because we have to look into incremental improvements, and that's for your own sort of assessment. So not drastic changes, but if you think that the tool actually needs to be fine-tuned, we could do that as well. So it's an opportunity to turn the political willingness and commitment to scaling up implementation in the coming time. So there are quite a few action points for us to take it forward, learning from your experience, and also harnessing on the political commitment and leadership into actual action in implementing the action plan. So there's one more point about, I think it's important that we create platforms, as was mentioned, through this network of sharing experiences in real time as countries are providing and filling in questionnaires, what challenges they are facing, how do we address those challenges, and what are the opportunities for cross learning at that time. So thank you very much. Thanks a lot. Joao.
Thank you. Thank you so much. Extremely helpful. Thank you. I see no further questions, so I now would like to invite the honorable delegate from Germany to deliver his presentation and updates. Thank you so much. I will have to leave you for maybe 15, 20 minutes, and I hand over for a while for my dear colleague, Mafaten, who will chair.
Okay. Good morning, everybody. My name is Klaus Heidecke. I'm a retired surgeon, and after retirement from a university career, I looked for another challenge, and so I joined the IQOTIC, which is the Institute for Quality Assurance and Transparency in Healthcare in Germany. And I would like to talk a little bit about the German way to patient safety. And unfortunately, I will have to dilute the wine Marfeten just put on the table with some water from the German perspective. In the past, Germany was actually the front runner in terms of patient safety. It was was contributing to the G20 summits quite extensively, and it was also part of the development of the Global Patient Safety Action Plan. And in the meantime, after I think 8 years of discussions, patient safety has actually become a national health target in 2022. But the Patient Safety Action Plan is on the website of the ministry, but really hasn't put into effect yet. And we are in the year 2023, and almost half of that is over already. So there is a little bit that we have a problem here. And the problem arises from the complexity of the healthcare system in Germany, which I will take you in a few moments through. And about the problem is also the number of the players who have an important issue there. So the healthcare system is set in such a way that you have a lawmaker and a ministry which sets the frame for healthcare in Germany, and then downstream of that, and that all the way downstream, you have the Federal Joint Committee, which is a self-government institution, which has basically a sub-legislative function. So it's the supreme decision-making body of physicians, dentists, and hospitals, and the health insurances. It specifies all the directives in a sub-legislative standard, and sets the catalog of benefits for the patients. That's 90% of the population, 73 million people are insured by statutory health insurances in a binding manner, and the other 10% are privately insured, so they basically have 100% coverage in Germany. So the Federal Joint Commission regulates the provisions of services by the about 2,000 hospitals, 180,000 physicians and psychotherapists in private practice, 63,000 dentists and 80,000 other providers such as physiotherapists and so on. So the Federal Joint Commission is under the supervision of the healthcare ministry, but basically it's not in a subordinate position or authority. So basically it's an indirect federal administration, and that's legalized on 2 paragraphs in the social law code. Now you have to imagine that this sub-legislative body is like a parliament. You have an aisle in the middle, and on one side is the representatives of the statutory health insurances. On the other side of the body is the 5 the care providers, such as the hospital organizations, the physicians, and the dentists. And then you have 3 impartial members, and they may tilt the balance to one or the other direction. So the Federal Joint Committee provides numerous quality assurance measures and can actually set directives for that. And I just underlined the ones which are important for quality assurance. So it sets the standards for measuring the interaction to promote quality in healthcare. It sets the state for minimum requirements for structural, process, and outcome quality. It sets the numbers of minimum caseload procedures in complex surgery and transplant medicine, for example. And it has a graded system of sanctions if people do not comply with the requirements, among others. And one of the institutions who served the Federal Joint Committee is my institute, the Institute of Quality Assurance and Transparency in Healthcare, which has its 8th birthday this year in January and is organized as a charitable foundation. So we work on behalf of the Federal Joint Committee. We develop risk-adjusted instruments for measurement of transsexual quality assurance, participate in transsexual quality assurance, publish these results, and using more and more social data. And these are the 15 operations we perform. And if you take a look at them, I don't want to go through with this, it's mostly heart. Then there's a lot of gynecology and maternity, and then there are a couple of other orthopedics procedures.
Некоторые процедуры.
I'm sorry? So these are 15 procedures, and it covers the tip of the iceberg, but it's not widespread over the whole area of medicine. And that's certainly one of the problems we are working on right now. And we have also some rules where we measure the structural quality for femoral fractures, staff requirement in psychiatry, maternity, aortic aneurysm surgery, and so on and so on. So these are the legal basis where quality assurance is practiced in Germany. There are also other areas where voluntary quality assurance and patient initiatives are working. And one of them is the Initiative of Quality Medicine, IQM. This is based or started by the Helios group of hospitals. Then Sana joined, a lot of the university hospitals have joined. So it's about 50% of all active hospitals, who cover about 60% of the patient load in hospitals. And they measure quality mostly on administrative data on outcome quality. And that is interesting because they use a peer review system for conspicuous hospitals with hospitals with conspicuous results. So there is a kind of a PDCA loop, so that quality is actually improved by visitors who tell institutions that they should have improvement, room for improvement. And then we have the VIDO, the Scientific Institute of the Local Health Insurance Funds. It's about 30% of all patients who are insured in Germany, and they have a risk-adjusted quality measurements on the basis of administrator on purely outcome quality, but in that they come up with a ranking reporting on medical adverse events and complications. So whoever is up for good results, and they have it with stars or 1 to 3 stars, you try to become at least not have the red taillight with you, and 20% of the hospitals are considered with the need for improvement. And thirdly, we have the German Coalition for Patient Safety, the APS, that may be known for some of you. It's an interprofessional association representing all facets of the German society, not just professional healthcare professionals, but others too. And they came up with numerous recommendations to reduce medical errors and improve patient safety. And one of the highlights were the white paper on patient safety and the Germany Recognizes Sepsis initiative. And then fourthly, we have a ritual of certification of medical centers, mostly orthopedic or oncological centers, stroke units, cardiac chest pains, and so on. And they take into consideration outcome, process, and structural quality parameters. So having that said, I should answer the questions why, what, and how, what's happening in Germany. And why is we are not as good as we should be is because it's historically driven by a small number of procedures. We started it probably ahead of everybody else or a lot of other countries, but it kind of got slower and slower. And patient safety and patient-centeredness was not always in the focus, because there were also monetary things which became important. And thirdly, other countries are actually much further ahead. So I think we have to do something. So what should be done? I think the horizon should be broadened. We should at least represent the whole spectrum of medicine, including rehabilitation and nursing homes. And most of all, we have to reduce the bureaucracy. As I said, initially, we have a very complex system which is governed by bureaucracy, and we have a lack of digitalization. If that would be the case, that we can reduce bureaucracy and speed up with digitalizing, I think we have a good way of catching up. So what needs to be done, and how can we do it? I think we have to readjust the balances between the powers of the players, the power of the players, and we have to definitely put a stronger focus on what's important for patients and for the society. That brings me to the last slide, which is a painting of Caspar David Friedrich, a famous painter of the modern art. The wanderer above the fog and I think we need to do more in Germany and speed it up. Thank you.
Thank you very much. I mean, I didn't have the opportunity, unfortunately, to follow all the presentation, but your last slide, in my view, is fantastic because it clearly identifies the what, right? What needs to be changed. And you're also identifying those, let's say, less positive areas in a very humble and open fashion. And I think we all in the room appreciate that. Reducing bureaucracy, increasing digitalization, expanding, like other countries also mentioned yesterday. I think that's really very simple and wise approach. I mean, it really identified what needs to be done. The how is a lot, it seems to me, a bit political as well, but focusing more on patients, I think everybody would agree, right? And that's really maybe the cement that can bring everyone together. Thank you for that. Thank you for that. Very good. Any questions? Yes, we have a question here from WHO HQ for Germany. So maybe we have a microphone we have 2 roving microphones, right?
Thank you. Actually, it's not a question, it's a comment. I would like to take the opportunity to recognize the role of the political leadership and governments of United Kingdom and Germany together to lay the foundation for the global ministerial summits on patient safety. And it's only because of that that we were able to get the global action plan, because that started a series of ministerial summits and that started the establishment of World Patient Safety Day. So the idea for World Patient Safety Day, the 17th September, that actually comes from the efforts within Germany. So I really want to acknowledge and sincerely thank German government and yourself for the leadership you provided globally for patient safety. I really, really wanted to use this opportunity to thank you for that. Thank you.
Yes. Extremely fair. There are really member states in our region that are driving the way in terms of patient safety. And that's really important. And we appreciate that. I think I can say that on behalf of everyone. I see no more questions. All right, then we move on with our agenda. Then it's my great pleasure to invite my colleague Christos Triantafylou to chair the next bit of the program that will take us to the break. So Christos, could you join me here and introduce the next speakers? Thank you.
Dear colleagues, good morning. I would like to welcome all of you to the next session, Quality of Online Health Information, Feedback from a WHO YouTube Joint Initiative. On February 2023, a team from WHO Athens Quality of Care and Patient Safety Office convened with a group of countries in Berlin to a joint informal workshop under the title Leveraging Online Information in Health for Improved Quality of Care. This was done in collaboration with the YouTube Health team and had the overarching goal of discussing the pressing topic of misinformation in health and its impact of quality of care. Now, Dr. Jose Pedro Teixeira will now briefly present to you the main take-home message from this workshop. After him, we will hear from the delegate from Austria, Dr. Wolfgang Geisler, on country-specific perspectives on this event. Dr. José Pedro Teixeira is a medical doctor with a public health background, but is a consultant at the WHO Athens Quality of Care and Patient Safety Office. José, the floor is yours. Enjoy your session.
So good morning, everyone. I hope you had an amazing evening. And for the ones of you that were at the dinner, I hope you enjoyed it. Let's just wait for a bit. Thank you very much, Dr. Christos, for your excellent presentation. And Dr. Wolfgang, if you want to join us already, I mean, you are invited to take your stand already. So after me, so that you know, after me, we will be hearing from Dr. Wolfgang from Austria, but also from our colleague Isda from Latvia, that will be also joining us online quickly to just give her her thoughts on this. I will try to, yeah, not yet. Okay. Yeah, don't worry. I mean, for the sake of efficiency, I can start by saying that I will be talking about misinformation and this event that happened in February in Berlin, as Christos mentioned. We had a couple of countries there. It was just a joint informal workshop with a team from YouTube Health. And this was really the first iteration of a process that we hope that will continue with all of you, all of your countries. And I mean, hopefully we can tailor specific solutions to the specific contexts of your countries. I can go without presentation.
Your presentation.
Until we'll get started, Dr. Wolfgang Geisler is a patient safety and quality reporting expert from a public health institution of Austria, and I would like to welcome to the floor.
Thank you very much. So I will be asking to skip slides. I won't be skipping myself. That's the only difference. I think people here will bear with me on this one. You can also thank Nefeli for her amazing work with comms, internal and external comms of WHO. Okay, here we are. So, for the sake of time, I'll try to make up for it. We can already go for the first slide, so I will skip the introduction, as I think you already understood what I come here to tell you about. Yeah, next slide, please. So, the first question I'd like to address, and I mean, sometimes we get so into what we are doing that we forget that not everyone speaks the same language. And I think it's very important for us to start with a definition. And so basically, what do we mean when we say health information? So health information is any type of information that is inadvertently false and is shared without the intent to cause harm. So this could be something that you would receive from a family member or from a friend that is just not true, but there was no intent to harm you. That is different from disinformation, which would be the same type of information, but that was purposely false and that was spread with the intent to cause harm. Next slide, please. So these are just two systematic reviews. One of it focuses on the prevalence of health information on the online ecosystem. And this team identified 6 main domains where misinformation is particularly prevalent. So the 6 domains are new tobacco products and drugs, diet and eating disorders, vaccines, as you may be aware, health interventions, NCDs, and pandemics. And the other systematic review I wanted to bring you really notes an increasing trend in published articles on health-related misinformation, but also the fact that for some topics, there is greater popularity on misinformation than it is on good quality information. And next slide, please. So I will try to quickly show you the relationship between misinformation and quality of care, and this was something that was addressed during the workshop we had in Berlin. Next slide. Now, we know for a fact that misinformation has the potential to intensify or lengthen outbreaks, as it can distort the interpretation of our way of looking at scientific evidence. It can obviously undermine public health response. It can lead to mistrust in us as health authorities. But really, and next slide, please, what is the evidence? And so that was a work that we did looking at the evidence and trying to merge it with what is quality of care. And we went pillar by pillar to check what was the evidence actually available. We found that for some of these pillars, so for instance, effectiveness, equity, and safety, there is a well-established body of evidence that actually relates misinformation and quality of care, so a negative impact of misinformation in quality of care. We can go through one or two of these during Q&A or after my presentation. I'll be happy to, but for the sake of time, I'll just skip it. You can have the presentation later, and I can give you even some of these papers. Next slide, please. So during our event, we had a colleague from our digital health team in Copenhagen, Dr. Kyrillos, and he presented one of the systematic reviews. Actually, this is an umbrella review, which is a systematic review of systematic reviews that was done on infodemics and health misinformation. And what Dr. Kyrillos presented in Berlin was that it was found in 10 studies, which is quite relevant. We are talking about 10 systematic reviews, that the effects of misinformation are as such, to reduce patients' willingness to vaccinate, to enhance misallocation of resources in health services, to weak and slow countermeasure interventions, and they were so important during the pandemic, but also obviously to exacerbate poor quality content creation, and this is something that should be tackled. Next slide, please. This is our graphical abstract that was created live during the event, and we would be happy to share it with you. We have it available, and just for you to know that a lot of things were discussed during this first iteration of the collaboration. Next slide, please. And what I really wanted to talk to you about is the why, what, and how we could be doing about this. Now, the why is pretty straightforward. Basically, it's what I've been saying so far. There is an impact of misinformation on quality of care, and we think that should be addressed. Next slide, please. On the what, it really comes down to any action that would make sense to you in your specific context, in your country, in order to tackle this issue. We, in collaboration with YouTube, have been discussing some options that may also be expanded to different partners, not only YouTube, and that could actually make sense to you. So one of these, and we can go right to the how, which is being discussed, and it's in a process of validation both in WHO but also in YouTube, would be the creation of a playbook that would actually be distributed among yourselves, so member states, and it would teach you how to create engaging and so quality health information. Usually we use this 4 A's approach when we are talking about quality of health information. We are looking for online health information that is accurate, accessible, authentic, and actionable. And these are really the 4 A's that we're looking for when you're talking about health information. Also, the how really comes down to any sort of action that you might think could be interesting for your specific context or country. And in a way, and as João mentioned yesterday, the next step is always with you. And that's why it's so important, this kind of interactions where we can really hear from you and things that could make sense from you. And we could certainly tailor our approach on next steps with you. That is it. Thank you very much. Next slide for the thank you. Yeah.
Thank you very much, Jose, for your brief and great presentation.
Thank you.
Let's move on with the presentation of Wolfgang.
So, good morning, everyone. It's a great pleasure to be here. My name is Wolfgang Geisler, and I'm from the Public Health Institute of Austria, nominated by the Ministry of Health as a focal point for the Patient Safety Network. So, I prepared just a short presentation, and it's like an add-on for the presentation Jose prepared. And I want to show you some information. I prepared some information what we experienced during this workshop in Berlin in March, and it was and now our experiences about from our country perspective, and I want to share information what can be done. So. Online information is found 80% via search engines, we heard, and not directly the rest of the 20% about going directly to the website, for instance, and 7% of these 80% is information is searched on health topics. We heard about search engines. Google is the largest search engine. For me, it was new that YouTube is the second largest search engine, with about 4.5 billion views on health information in 2022, just in Europe, and 110 billion views worldwide. So, and the YouTube, the channel is, the annual growth is around 20%. So it's growing increasingly. The prevalence of false health information is a big problem. We heard already. For instance, e.g., the 1/3 of health information disseminated via social media on cancer is misinformation. So there's also a tool about the reporting misinformation online that is hosted by the WHO. But the problem is that misinformation, there's so much content on a daily basis that if you report misinformation on social media, you can do that, but they try to get it offline. But the problem is there's so much content. So what can be done? It's online information is a very important part to strengthen health literacy in the population. And it's also, as we heard, and also it's in the action plan, it's an important contribution to strengthening patient safety. The aim is to improve what the WHO and YouTube and Google Germany promoted is that the aim is to improve the ranking of quality health information. And by doing that, it's is to create a label for good health information. So the borderline content should be reduced by making good health information more visible. So the producers of good health information can be accredited by YouTube. So the goal is to strengthening health literacy in the population, and it can be supported by good online information. Just a second. Because the way of consuming information has changed in recent years. So providing videos can help to reach more target groups for topics So videos can play the role of an icebreaker to get deeper into a topic, or maybe they can target a younger target group. So videos can improve the accessibility of the information provided. So what we have in Austria, it's an own platform for evidence-based health information for the population. For several years now, the content is growing fast. And what we learned in Germany is creating more videos. And these, we take this into action and more. And I talked with the leader of gesundheitgv.at, and they try to produce more and more video content and embed it on their platform. So what can countries do? So they can promote the label of good health information on wherever possible, among stakeholders, among their own ministry or organization, to provide high, good video content. And what else can we do to provide informations about how to create content by checklists, toolkits, guidelines, and how to make good health information online. You can also encourage health professional partners, stakeholders to produce their own content and get accredited. So, yeah, getting accredited is a good way to create a good high content and to make a good and provide this information, make the ranking of good information online better. So that's for me for today, and thank you for sharing this content.
Thank you very much for your
Thank you.
presentation. Thank you very much. Now we will proceed to the delegate from Latvia, Dr. Irisa Zile, who will join us online and provide her input on this event. Good morning.
Good morning. I hope you can hear me.
Yes, we can hear you.
Okay. Yes, I'm from Latvia and from Center for Disease Prevention and Control. And my background is public health and epidemiology. My presentation maybe will not be similar as previous speaker. I just put more information what we have already about patient safety and healthcare quality, but I add with myself about this working group meeting, because maybe my first expression was after these meetings that, wow, it's so maybe high-level IT resources using all these YouTube platform, different kind of video and so on. And it feels in the first that maybe in our country, not all these possibilities happens or we have, but then I just start to think more and think, okay, what can I do with all existing resources? And of course, I also took some home messages, for example, that how we can put more visible this information about patient safety and healthcare quality, and especially for public that they know about later what I show this, for example, patient-reported experience measures, because a lot of persons, when they admit, for example, hospital, they maybe don't know about the possibility to fill this questionnaire and give feedback. And that's why maybe we not produce enough of this information and so on. Yes, and please, next slide. The first, regarding this patient safety and health care quality, I just would like to highlight 2017 year, maybe when it's more like the beginning point when these things more was included in legislation framework, and we start more think about it. Please, next. And of course, after this implementation of concept, we expect that increased also patient safety, increased patient trust in healthcare system, because also have some surveys that we can observe that there people don't trust the healthcare system. It's the same, they don't trust governments, and we need to improve this situation. And of course, also a common understanding of healthcare quality process. And future wide state goal, of course, also the strength and protection of patient rights, providing patient-centered health care. And of course, all these things we just can reach if we have this communication with partners, with public that will give them all this information. I think this is one topic. Yes, and it was just a roadmap about these patient-reported experience measures, and also here we start with some pilot projects, and we cooperate with international partners, and it also shows how good collaboration networks that we can learn from other countries, other experiences. Thank you. Next slide. And also we can see some progress that hospitals will join this patient-reported experience measure system increased, and we still work on it. As I said before, that we now after this meeting, also when I came back, we start more work with some new information booklets for public, for patients, and together with hospital also make some new information, some paper. Here just I put some slide about this information that we get some data to OECD and to these platforms that it could be international use. Please, next. And of course, also, as I mentioned before, about these collaboration networks, we have this quality working group. We work together with representatives from other institutions, with hospital, with how to motivate these managers from hospitals, health centers, to work more with also these quality things, more informed patients, because we can see from data that in these hospitals there are a lot of work done from these managers, this response rate increased. And or this also task is again to work with them and put more in action all this information. Thank you. Next slide, please. And yeah, here are also just some international comparable data also to this OECD, the healthcare quality indicators in primary acute mental health care, and from last year also some new indicators about end of life care indicators, and of course about all these statistics also. We should more maybe think about how to produce a more visible way these things within our country, and maybe more attractive that people can more understand, and to improve this literacy about what we all thought. A lot of talk was in this working group. Thank you. Next slide. Yeah, and thank you for your attention. And as I said before, that the main message from this working group is that how make these things happen and put more information using already existing or IT resources, solutions. Of course, we always want that this digitalization will be more faster and better, but maybe not so going so fast, but in any way, I think we can do a lot, and we work on it more After that, also we put some short messages in social media, for example, in Facebook and other, or CDPC work this account that people get more information and can see and get more visible. And also we hope that it helps to get more these response rates. And about this trustful information is also previous colleagues speak. This also under our CDPC institution, but there are now some specific maybe information portal about patient safety or healthcare quality system. Maybe it's also somehow could establish more and new things. Thank you for your attention.
Thank you very much for joining us online and for your presentation. Now, do we have any questions? I think we don't have any question. Joao.
It's a comment and maybe question for Jose. I mean, in terms of what I would like to, in a way, launch a provocation in terms whether U.S. representatives of member states would consider that you need to do more work around the quality of health information online. Would you, I mean, before this presentation, would you ever thought about the fact that maybe this is important? Because if you have, I mean, there's so much information that people really get online nowadays, that it's really, as it was shown very clearly in Jose's presentation, that probably this is something we cannot ignore. But at the same time, it's a big challenge because to be relevant, you have to engage with big players, other stakeholders, which are far beyond the traditional collaborations that WHO and probably your ministries of health can engage with. We're talking about giants like Google, YouTube, Microsoft, and others. So, but also to ignore it, I don't think is something we can do. Because if this is affecting vaccination rates, if this is affecting people seeking treatment for cancer, can we just put our head under the sand and ignore it? Or do we have to address it in terms of our plan? So it's a bit of a provocation, and maybe asking Jose, how does he see it in moving forward? How can we engage? Because there's no way to engage with these. We cannot be effective if we don't engage with these other stakeholders and players. I remember in Berlin, we saw one couple, two doctors, one couple, German couple, that they are influencers. They have 2 million followers. I mean, it's massive. People, they can do more in one day than I can do as a public health professional all my life. So if we don't acknowledge that, I mean, difficult, right? So how do you see it? It's a bit of a provocation, and I apologize for that.
Great provocation as always. We also have Martin, but maybe I'll just address what John said, and then I'll give you the floor. And we also had this French kinesiotherapist, and in discussion with us, he told us that he loved being one-on-one with patients, but online he was able to reach millions of people. So the range of what you can reach is absolutely different when you are talking about using these kind of platforms to convey online health information. In terms of what we can do, that's really a great question. And I think it ultimately comes down to countries. Obviously, WHO can suggest some alternatives. I think the playbook could be one of them. YouTube actually showed us that you don't need a lot of stuff and a lot of high-tech technical stuff to get out with great online health information. There was this president of one of our member states that has a very active YouTube channel, and he mostly uses footage from his cell phone. So they really showed us that it is possible to convey very interesting information with very basic tools, and this is actually doable, and it can be applicable to healthcare In a way, we can reach our patients easily if we use these sort of platforms, while acknowledging that we need it to be actionable, accessible, and obviously authoritative. Martin, please go ahead.
Yeah. Well, I just wanted to add to the brainstorming a little bit. I mean, this is obviously a very wide field, and it's always difficult where to draw the boundaries for some particular aspects. But one of the issues which I think you are all dealing with in the quality of care provision is it's either the formal requirement to maintain a report on the quality of care provided by hospitals, for example, or healthcare providers, which is in some countries there. And I guess you are struggling, and I'm preparing the informal discussion afterwards. The other thing is all these rating portals which are there. You are searching for a dermatologist online, and you invariably end up on a rating portal, which tells you they are rating the quality of the providers. And the foundation for this rating most of the time is very unclear. Somebody is publishing something, is very unhappy most of the time and gives a miserable rating, or somebody is bored and gets something else. So again, there is a wide field of things which is influencing customers' perception about the quality of care which is provided to them. And I just wondered whether this could be a theme for one of our upcoming meetings, how you are dealing with this and validate it if there's any validation possibility.
That's a very interesting topic. We discussed mostly the platforms and not really the results from, for instance, Google searches, but that could be interesting. I mean, one of the ways that this could be addressed is through validation. So for instance, if you search, and they showed us that on YouTube, and it's already rolled out in some countries, if you search for information on diabetes, for instance, YouTube automatically would put out a health desk, and you'd be able to select from validated sources, information from validated sources there. It's not so much at the level of the provider, but mostly looking at what patients could be looking at in terms of health information. And I mean, then again, as Ron said, we are talking about YouTube, but this could be the same with Google or with Microsoft, any of these solutions that people actually use. So this is actually what people use when they want to get information. And I think that it makes sense that us at WHO and every healthcare stakeholder should be there as well, trying to validate what's good information and trying to get people away from misinformation or disinformation, which would be even more harmful.
Any other question?
Okay, thank you very much. Please feel free to reach out to any of us during breaks if you are interested in this topic. Now, before the coffee break, I'll just give the opportunity, and let's just check if they are online, to Dr. Guillaume or Jean-Baptiste Beauvau, because I know they have been having some technical issues on their side. Let's just check if they are online. If not, we'll just go directly to coffee break. Yeah. Let me just check one thing. So this is a coffee break, right? This is the one. So if not, we will convene in, I would suggest we do a 15-20 minute break, and we'll be back with Ms. Ageliki. Yes, I already called out their names. Probably they are, I mean, they told me they were having some technical issues, so maybe let's just skip to coffee break, and then we'll reconvene with Ms. Ageliki later. Thank you very much.
Thank you very much for joining this session.
Hi, everyone, again, and welcome back. I would like to ask Dr. Jean-Baptiste if he's online and able to present his slides on the Betty project. So briefly, for 5 minutes, we'll hear from our colleagues from France, and afterwards we'll reconvene again with the regular program. This was scheduled for before, but yes, perfect. Dr. Boval will share his slides and we'll go from there. Wonderful. Welcome, Dr. Boval.
Yes, thank you very much, everybody, for your invitation. You can see my presentation. It's okay for you? Yes, you can see. It's good?
Yes, perfect.
Okay, perfect. Thank you very much. So I just want to present me. I'm a urologist in France, in Toulouse, in the south of France. And we are with my friends and associate, another urologist, Guillaume Ploussard. We create an application of whose name is Betty, for better surgery. And it's the name of the first woman in surgery in Europe and in America, whose name was Elizabeth. So it's a little remember from it. So we want to create something. We create something in your department of urology, in your private hospital, and because of some difficulty to do the same system in other country, we want to make an application for every surgery, for every patient, and for every surgeon. So Betty is the first online digital platform with free access, aiming at decreasing surgical risk and optimizing operative care pathway. Why? Because with the WHO checklist in some years, we have just papers in a surgery room, and we have no digital application for all the care pathway, and it's really a problem for all the patients. So we want to create a general digital pathway and suite, and for the following specialized care pathway for any patient and any surgeon. So we want to reduce all the problem around the surgery. Why? There is 20% of cancer surgery in France and in the world. There is 20% of not of safety procedure failure, and the WHO checklist, for example. There is 30% of misunderstanding of information for all the patients, and at least 25% of complication after surgery now in 2023, and 4% of mortality in Europe after surgery. So we have very bad numbers in modern surgery. So we want to improve that. So we create an application with two sides, for the patient and for the surgeon, who can be able to improve the risk of complication before surgery, during surgery, and after surgery. This application is created. It can be on the store, Google Store and Apple Store, in a few days. And I just want to present you some face of this application. It's just to improve surgery, to be more simple for all surgery and for all patients. So you are just to make the subscription for the patient. You just make the subscription for the surgery, for the surgeon. There is a good matching, and we can have all the care pathway for your surgery. You have two levels of pathway: the general pathway for all the patients, with improvement of everything, of your alimentation before surgery, of your sport before surgery, and specific pathway if you have urology surgery, gastroenterologic surgery, cardiac surgery. So we can do everything. What is the advantage of the application? For patients, you have safety module with QR code and checklist. So there is no risk during and before surgery. You have a pre-op preparation, and this name is prehabilitation. and we make a lot of paper of that of the rehabilitation in the department, and we can see we improve the rate of complication and everything before and after surgery. There is educative content, video motion, podcasts. There is universal content for all the surgery, diet, physical activity, smoking cessation, etc., anesthesia. And we can create specific modules according with each intervention, each surgeon, each hospital. And we can do after telesurveillance at home. For the surgeon, it's a real-time access to all important patient data. It's complication risk assessment for each patient. We can have perioperative pathway automation. We can have telesurveillance after surgery with modulability according to individual risk of each patient. And we can have alert of rapidity and complication management. So Betty is simplicity, applicability for everyone, modulability and measurability of everything before, during and after surgery. I say to you, we prove some benefits, and we have the paper. We prove there is a reduction of length stays at hospital, 4 days to 1 day, reduction of complication, 8% to 5%, and we improve the outpatient in 1 day surgery from 20% after this program. So same discharge is big improvement of 60%, and the length of stay is reducing. We have other function in the next step of this application. We do ongoing fast trial comparing this program versus standard of care versus nothing, no prehab. We can do patient-reported measurement for everything. We can use artificial intelligence in this program to improving risk assessment and educative content. And we doing that in the next future version of this Betty application. We have partnership with scientific society in France, urologic, digestive, and in Europe. And you have we're working with this scientific society. We want to make a translation of this application worldwide for all the country, and to include in developing country in Europe, but in other country. And we want to show and to improve health economic benefits assessment at a national stage. So thank you very much. It's a very short presentation, but I hope you understand everything of Betty, and we want to improve surgery for the future.
Thank you very much, Dr. Bouval, for your amazing presentation on this such an interesting project. Now I'd like to call to the stands Dr. Angeliki Katsapi to talk about the harnessing of the part of digital to improve quality of care and patient safety. And you can probably get on the stage also Tino Marti and our delegates from Greece and Israel as well.
Thank you very much. Good morning, ladies and gentlemen, dear friends. My name is Angeliki Katsapi. I'm a consultant for the Quality of Care and Patient Safety Office of WHO Europe. And I'm really delighted and honored to coordinate this significant discussion on the digital power and how it can be harnessed for the quality of care and patient safety enhancement. I would like to, first of all, to make a short introduction about digitalization, which has been evolving as a high priority, top priority for healthcare systems. And it has been used traditionally to enhance efficiency, effectiveness, to control operations in the healthcare delivery, or to create consistent health data to be usable for research or for decision-making in healthcare. But nowadays, as we've heard from our estimated colleague, Dr. Henrike Martins yesterday, we are called, we are asked to use technologies in a more disruptive way, because through disruption, we are able to transform the way that delivery of care functions. What Dr. Buval just a few minutes ago presented, it's an excellent example on how we can transform the delivery of care. We saw the individual risk assessment through applications and this communication with the surgeon before. So the perioperative safety cycle is driven by technology. But at the same time, we have to consider the human factor. And I recall what our dear delegate from the Netherlands mentioned yesterday, that innovation should also involve the people. So we have to consider also people's engagement. At this point, I would like to present the next speaker, which is our colleague from Australia. It's Chris Boyd-Skinner, an intensive care clinician working for Australian government, working on standards. And today, Chris is going to present some conceptual thinking on the shifting focus from quality of care and patient safety problems to innovation challenges. Chris, thank you.
Good morning, everybody. Thank you so much for the opportunity. It's a privilege to be here among such esteemed colleagues, and thank you for having me from all the way from Australia. So as Angeliki said, I'm a consultant with World Health Organization's Quality of Care and Patient Safety Office in Athens. I'm a clinician by background, intensive care, neurological and trauma. And for the last 5 years, I've been working for the Australian government's safety and quality arm, working predominantly in digital patient safety. So the aim of this morning's presentation really is to describe some concepts which can be applied to quality of care and patient safety issues in healthcare. So that is applying a design thinking approach to problems and turning them into challenges for policymakers, for healthcare providers, and also for representatives of ministries of health. So today I wanted to present some concepts around using design thinking to shift the emphasis from problems to challenges. And in addition to that, I wanted to present 3 short case studies from Australia where we have considered some very large patient safety problems and used design thinking as a concept in order to innovate. So it's probably no major surprise to everybody in this room that healthcare is very complex. And we're also faced with many problems, and we've heard some examples of some of those significant patient safety issues during the presentations this morning. However, this also presents great opportunity to shift those problems to innovation challenges. And by reframing healthcare safety and safety and quality problems as challenges, we can approach them with a challenge-oriented mindset. And there's a range of different benefits to doing this. Challenges are considered to be much more motivating than problems, and obviously there's some psychology behind that. But it's also an opportunity to inspire creativity and innovation, and particularly involving patients and also clinicians in that creativity and innovation process. It also presents an opportunity to encourage collaboration and teamwork, utilizing the really rich data sets and insights that we collect quite regularly through the provision of healthcare, things like patient-reported outcome measures and experience measures and patient information surveys. And it can also lead to more sustainable quality solutions that, when implemented, become business as usual for the healthcare workforce. So this concept of design thinking has been around for a very long time, but perhaps is only more recently being applied to the healthcare context. And it's been used to develop a wide range of healthcare solutions, including the development of new medical devices, patient communication tools, and healthcare delivery systems. And again, in the context of healthcare, it's been applied recently to increase efficiency in healthcare and also the effectiveness of healthcare by doing something very, very simple, and that is increasing the focus on both patient and provider needs. The methodology focuses on the concept of empathy, and a concept that we also hear a lot about, which is user-centered design. And this makes design thinking a really valuable tool for improving patient experience and outcomes in healthcare. Design thinking largely involves understanding the needs and perspectives of patients, of their families, and caregivers. And this makes a lot of sense and makes design thinking a really valuable tool for improving patient experience and patient outcome. You can see the stages up there on this slide, and in the interest of time, I won't go into them in too much detail, but it typically involves 6 stages: empathize, define, ideate, prototype, test, and implement. And each stage is designed to build on the previous one with a focus on an iterative, user-driven process. What I would add is that we do not finish at the implement stage. This is a continuous cycle. We need to continually go back and consider what the patient needs are, what clinicians' needs are, and what families' needs are in a continuous process. And we need to do this in order to increase the benefits to our patients and change. So I now have a few case studies to present to you this morning from Australia, where design thinking has been applied for some really interesting and high-value innovations. 2 are focused on digital and 1 is non-digital. So the first case study focuses on the recent development of digital mental health standards. And for the last almost 2 decades, Australia has been a global leader in digital mental health service provision. And these are services that are predominantly delivered online via things like mobile applications, online web-based tools like online cognitive behaviour therapy, and then online mental health assessment services, which might be done using telehealth. However, the sector's faced a number of really significant challenges. We've had this rapid increase in the development of digital mental health technologies and their use. There's also quite a lot of variation in terms of the safety and quality and efficacy of these tools. And quite recently in Australia, because of COVID, we have had a significant overburden in face-to-face mental health services and considerable population growth outside the metropolitan areas. So one of the big challenges for us in Australia was to understand what regulatory levers we could use in the context of standards in order to improve the safety and quality of services. And it was also really important for us to consider really clear messaging to patients, service providers, and clinicians, so they could understand that these types of services are just as safe and effective as face-to-face mental health services, or can be. And then also using data and co-design principles to inform the development of these standards. So we launched the standards in 2020, and the primary aim of them is to improve the quality of digital mental health provision and overall protect patients from harm when they are using these tools in an online environment. There's 3 pillars: clinical and technical governance, partnering with consumers, and model of care. And just recently in November last year, we started a formal accreditation process where services can be assessed against these standards. And if they are successful, they get a digital accreditation badge to put on their tool. And that's important because it signals to people using these types of technologies that they are safe and high quality. Another significant challenge in Australia is low value care. It's been quite significant, a significant issue for the Australian healthcare system. And when I say low value care, I mean that refers to medical treatments, tests, and procedures which provide little to no benefit to the patient and potentially can cause harm, waste resources, and also increase healthcare costs. So that's quite a significant challenge because it requires this shift away from a fee-for-service model, which has been used in Australia for a very long time, to get clinicians and healthcare providers to start thinking about how they derive the maximum amount of value out of the care that they deliver to patients. So one of the ways that the Australian government addressed this was the Choosing Wisely campaign. It was a national initiative, tripartite support between the Australian government, between the medical colleges, so nursing and medical colleges, and also those organisations that represent consumers. The purpose was really to encourage healthcare providers and patients to think very clearly about the type of tests and procedures that they were applying to their patients, and also encourage that shared decision-making and consumer empowerment, which is really important. And we really emphasized on the fact that we wanted consumers to be a very strong part of this campaign, encouraging them to ask questions of their clinicians to understand what choices were being made about their healthcare. And the final innovation that I wanted to share with you this morning is a relatively new one. This is a virtual intensive care unit that was set up in Australia a couple of years ago. One of the main problems that we had was access to highly skilled and specialised intensive care staff. And because of Australia's large geographical size, we had quite some substantial issues in getting access to intensive care services in a timely way. So the challenge that we faced was, how do we use the existing digital health and IT infrastructure available to us, and how do we rapidly accelerate that, because COVID-19 obviously was a big issue and a barrier to patient transfer from regional areas in Australia to the metropolitan centres. So the Royal Prince Alfred Hospital in Sydney set up a virtual hospital service, which included a virtual intensive care. And there was a relationship between the hospital in Sydney and hospital in Broken Hill, which is about 1,000 kilometres west of the centre of Sydney, so quite a considerable distance. What they managed to do was utilise the existing digital health infrastructure to allow for real-time telemonitoring of those regional patients and have the pooled skills of a multidisciplinary team, so on-call intensive care specialists, remote pharmacist team, and also nurse practitioners to assist those less skilled clinicians that were working in Broken Hill. So what we found was, we had this total system interoperability. We had shared digital interfaces, so electronic medical records, electronic medication prescribing systems, and real-time pathology and diagnostics capabilities shared across both of those services. So in summary, thinking about applying that challenge-oriented approach to safety and quality of care problems can, in effect, allow for creativity, can allow for collaboration and more sustainable healthcare solutions. Applying those methodological frameworks as well can be quite useful in thinking about how to best articulate and understand the problems. And the final point I'd make is about patient centricity. This is so key to everything that we do in quality of care and patient safety. We need consumers driving the decision making and ultimately being involved in informing the models of care that we deliver to them. Thank you.
Thank you very much, dear Chris. Really fascinating examples from your country. I would like now to invite Tino Marti, my colleague who works as a consultant at the WHO Quality of Care and Patient Safety Office as well, and he's a healthcare informatics specialist. He's going to elaborate further on the matter. Dear Tino, thank you very much.
Thank you very much, Angeliki. Good morning to everyone. This presentation is to share with you one of the initiatives that we are developing in the Quality of Care Office here in Athens. It's related to digital, but it's looking to digital from a different perspective. We have listened and enjoyed actually this experience from Australia or other solutions that we have seen before, which have all a quality dimension. So we are improving health services through digital health services, and we have to be sure, and Enrique's framework to assess quality of telehealth is a good example. So we have to look to quality when we look at digital health solutions. But in this initiative, we are just reversing the look, and we are looking at quality and see how digital can improve quality, but quality not on the health service delivery, true also, but on quality improvement strategies. Most of the quality improvement strategies that are in place, they were conceived before the digital revolution. So the question is, can we digitally transform quality improvement approaches? This is the broad question that through this exercise we are trying to answer, and this is work in progress. So we are going to share something that is being built with a team led by Enrique and Joao in the office, and with the participation of other members. So first of all, I would like to recall the situation. We are in 2023, and probably this is a landmark year. Many things are going on around artificial intelligence. We are still not capable to understand the transcendence of these changes in not the last issue, but the issue before the last issue. In the economies was this very nice cover with AI and all the controversies in terms of is it positive, is negative. You have heard probably this proposal of making a sort of stop in the development of artificial intelligence to have enough time to reflect on this consequence from a policy perspective. And also, if you have followed a little bit the transcendence in terms of the power that this session was entitled Harnessing the Power of Digital. So the power of this transformation is something that we have not able still to grasp. And you can see in terms of the computational power, how this has increased over time. And we are reaching this what is called the singularity point, where machines will be much capable of performing tasks that the entire humanity. So we are really in a tipping point. We are in a tipping point, and all these discussions that we will share now today with you were discussed even before this news. So there is clearly a digital revolution that can be connected with a digital transformation. Countries and policies are well aware of this. Just to mention a couple of them, in 2018, the European Commission produced a communication on digital transformation of health and care based on 3 pillars: giving access to citizens to data, improving the secondary use of health data, and empowering patients and healthcare providers through digital tools. Even these 3 basic pillars are still far from being reached in many countries. We are struggling to give access to citizens to their own health data. Sharing data between healthcare providers is in many countries still something to be achieved. Recently, it was approved at regional level, the Digital Health Action Plan that is calling countries to invest on digital health and improve these infrastructures to achieve the promise of digital. So we are in the process of digital transformation, while digital is going even faster than we can cope with. At the European level, probably you have heard about also the proposal for the regulation of the European health data space, which will have a potential use on the domain of quality. So this is the context we are working. The question is, can we digitally transform quality of care strategies, policies, and improvement activities? And one starting point was this report from 2019 that was analyzing the situation of quality of care improvement in the European region. And one chapter of the report is dedicated to compile the different quality lens was described, and it explained 5 of them. The first one is the traditional dimensions of quality. Here there are only 3, but this can be expanded to the traditional 6 or even the 7, adding integrated care, effectiveness, safety, responsiveness, equity, efficiency, access, and integrated care. Also the 4 functions of healthcare, from preventive care to acute, chronic, and palliative care. The 3 main activities of quality strategies: assuring improvement, monitoring, and setting standards. The traditional triad from VEDIS Donavedian, structure, process, and results. And finally, the targets of these quality strategies to improve the quality of healthcare professionals, of technologies, of provider organizations, patients, and payers. You can see in these compilation of the 5 lens, the technology is only covered on the top and the last lens on one of the targets, like checking the quality of a digital health solution, for instance. But our thinking was different, can digital improve all of these dimensions and strategies? And our answer, or our provisional answer to this, is we have to add a 6th lens. And this lens is what we call the digital lens, and is the lens from where we want to revisit quality of care strategies. And I want to introduce you probably for the first time this framework, this digital lens, which is divided in 3 main functions: digital for assessing, digital for assuring, and digital for improving, and 6 specific domains. I would like to give some examples. I will give an example for all of them based on patient safety. But I think one of the core elements of this digital lens is when we look at everything from the data perspective. And measurement has been tantamount for quality of care improvement. And through the investment that we have done in the last 20 years in health information systems all over the world, there is a richness of data that we can activate, and we are not always activating. Sometimes that is because there are constraints in data privacy, sometimes it's a matter of interoperability between systems. But once we have the opportunity to join this information and share this information in the right way, the potential of quality improvement is vast. I would like to give the example of, and probably you're familiar with the improvement of quality of care in primary healthcare. While you have a primary healthcare electronic health record, the information that is used for primary use for interaction with patients is automatically analyzed, and you can produce quality of care indicators almost in real time that can show you the level of performance of your practice as a family doctor, for instance. And you can have like annual goals where you want to reach. And if you are not reaching that goal, you just click in the dashboard on this very quality indicator. And there is the list of patients that are not helping you to reach that goal that is set for this year. Like, for instance, good control of diabetic patients as a quality of care indicator. So you see the patients that are not under this, so you can proactively address them in collaboration with your team. And this information can be also compared with your peers in your family practice. If there are, if it's a multidisciplinary practice, you can compare with other providers in the area, and you can compare nationally. So there is this comparative effectiveness that can be elaborated through measurement. So this is one element under the measure, the quality indicators that are much more easier to develop now than it was in the past. And also there is something that is really important. That is, we have used to measure quality on the process domain, while we have in some way neglected outcomes. And the reason probably was because it was difficult to get data from on the area of outcomes. So we can only improve what we can measure, and we were more able to measure activity or measure processes than measure outcomes. But we listened yesterday from our colleague from South Korea on the patient-reported outcomes and how they have evolved over time through technology to capture information on patient-reported outcomes. So this is something that is coming on and is something that digital is helping to move from process to outcomes. Protect is another domain, protecting patients and professionals. This has different derivations in the area of patient safety, and we will see it now in one example. Digital can also facilitate actions. This is together with conditioning behaviors, is related to behavioral economics, to inform decisions, to clinical decision support systems that can be built based on this data, and also with the use of artificial intelligence can help health professionals to improve their practice. At user level, through the mobile health applications, we can expand the capacity of reaching users beyond the physical encounter in the health facility. And through this system, we can include or introduce quality improvement strategies that take into account users as agents in the care. And the last one, which I would like to emphasize, we are in the process of developing the framework and illustrating this with examples, but there is a potential use of digital to improve quality under this domain of 4C, so anticipate what will happen. This is really emerging. We are still in an infancy. The concepts of digital twins, for instance, or the concept of command centers in hospitals are good examples. So we have all the data, and from this data we can monitor what is going on and what can happen if there are some, like in a scenario planning, there are some variables that are changed. So you can anticipate what will happen and then prepare the health organization to react on this. This can be done at healthcare professional organizational level, but can also be done at health system level. So finally, one example, sorry, this was discussed and prepared before ChatGPT was publicly announced. So this is a call to Enrique and the team to rethink along the line of this innovation. So we will probably have to give an update of the 6th lens, maybe adding a 7th lens, I don't know. So just a very simple example based on patient safety strategy, in this case from Portugal, based on 5 pillars: developing safety culture, the leadership and governance, communication on patient safety, prevention and management of safety incidents, and safe practice in safe environments. If this is, in this case, a patient safety strategy, how digital can improve the implementation of this patient safety strategy. For instance, safety culture, if we are under this 4C domain, where we have an information system that can anticipate problems, and we introduce the safety culture component into the system, we are addressing safety culture from a digital perspective. In leadership and governance, and this is related, in fact, to 2 elements: digital skills or digital capacity, digital thinking of leaders, also health professionals, and not everyone involved, but leaders particularly, because are those that are making the decisions in terms of investment and development of new services, but also stakeholder collaboration. Here is a huge potential in the governance element, and particularly in places where the complexity of making decisions is wide, introducing the digital component that helps collaboration. In terms of communication, this capacity of involving families and citizens in reporting patient safety incidents through mHealth applications, still in the process, but with some experience across Europe. In the prevention and management of safety incidents, the integrated digital systems with feedback to health workers and data to inform better health decisions. And finally, safe practice in safe environments is related to the application of quality in digital services. So it's the other way around. Last slide, just to recall the work that under this conceptual digital lens we are developing will be certainly fit by the Open Quality Initiative that was presented yesterday, and we are really happy to open the doors for your participation in this initiative of the Open Quality, but also in reflecting how digital can improve the matter of our discipline, quality of care and patient safety. Thank you.
Thank you very much, dear Tino, for this informative presentation. I would like to kindly invite for his presentation our delegate from Israel, Shaul Dolberg, who is the Director of the Division of Quality Assurance in the Ministry of Health in Israel.
Good morning. Thank you very much for inviting me. My name is Shaul Dolberg. I'm a physician, a pediatrician, a professor of pediatrics, and currently I'm a Quality Assurance Division Director in the Israeli Ministry of Health. And I'd like to talk to you a little bit of what the thoughts of the Israeli Ministry about new technologies, their effect on healthcare system, challenges, and in the view of quality and patient safety. So I started the first sentence with paper records. I would like to start a little bit earlier and mention Hippocrates, who was a physician, the father of modern medicine, who gave us the Hippocratic Oath. He was practicing medicine here in Greece, in the island of Kos. And I think that when he was riding his donkey from patient to patient, he didn't think about paper records, he didn't think about processes and digital technologies, definitely not about artificial intelligence, but he was going and seeing his patients. And when I mean seeing his patients, he's not really seeing with the eyes, just palpating, just listening, smelling, even tasting. I can remind you that the diagnosis of diabetes was done by tasting patients' urine before, many years ago. So the fact that medicine or medical treatment has changed from face to online has a lot of implications. First of all, what are the pros? There are many good things. There's definitely an increased access to healthcare. A person who is working can go with his cell phone, give 10 minutes of his working time, go to the office, close the door, and consult with a physician. It's very, very convenient. It's time-saving. It's cost-saving because you don't need to build so many clinics, so many hospitals. There are some data that show that online consultation improves patient outcomes. And also what we are interested in having is patients who are engaged in their own treatment. They self-manage themselves. This is something that we consider some of the pro. Now, there are definitely technology limitations. In our country, some people use a technology called the Taito. I don't know if you're familiar with that. It's a small device. You can put it on your heart. You can put it on the chest to hear the breathing sounds. You can look at the mouth or the ear. I think that there are many limitations to this device, to this technology. Also, physical interaction is mandatory. When I was training in pediatrics, the chief of service taught me that the first important thing that a physician should know how to do is look at the patient, at the baby, at the child when they walk into your office. You can make understanding whether the patient is very sick or not very sick. You can see how the patient walks or how he's carried by the mother. You can think whether the baby needs going to ER immediately or they just need some kind of calming down of the parents. There are diagnostic limitations. There are several regulatory and data barriers, and also privacy and some security concerns. Now, we're looking at new patients in this era, and also new physicians. So in a survey in Israel, 84% of adults are e-patients. E-patients meaning that they can and will use the internet, they themselves or immediate relatives. About 5% earlier, the presentation from Austria said 7% of Google searches are medically related, so people are looking for data online. And in a survey, about 3/4 of population are interested in having online interactions. The population have very high expectations. They demand a lot. They do want to become part of the decision process. And how do they become part of the decision process? They are getting information. They are getting advice online. They have Facebook for hyperlipidemia. They never know who is the party who is advising them. Is it misinformation or is disinformation, as Dr. Jose just taught us? And many of them use applications for health promotion and personal recommendations. We need to take care of all these things when we use digital world in order to enhance patients' health. Now, the physicians have also changed. They are called the Generation Z or Zoomers. They are all global. They can work all over the world. They are visual. They don't read papers and books like we did when I was a medical student. They are very, very technological, much better than myself. They are born to the online world. They are always online. You can see them sitting in conferences with their telephones all the time. You know, you say something, within 2 minutes, they criticize you because they already found on a Google search, whatever, that what you said was maybe incorrect or maybe different. They are much less focused. They want to do everything very, very fast. They have short attention span. I'm not sure if you heard the acronym TLDR, too long didn't read. You know, you send them a paper, too long, I didn't read it. Just shorten it for me. They definitely seek better work-life balance. They want to work less. Now they need to use multi-platform. They need to use various forms of digital technologies. What I wrote is that they need digital interpersonal communication abilities. So they need digital interpersonal communication by having 3 kids who are Zoomers, definitely need also better interpersonal, non-digital, person-to-person communication abilities. This is something that we need to work on. And, you know, they need to comply with huge information growth. Medical knowledge doubles itself twice every year nowadays. So it's really something that we need to think about it. And also ChatGPT that was mentioned earlier, we need to think how we use it and what are the drawbacks. Now, in the Ministry of Health in Israel, we think about many things. I won't go into everything, but we talk about environmental factors. We talked about social and financial factors. These were mentioned in some of the previous talks. We think about health-related behaviors like smoking. Are you familiar with what is called the roll-ups? Roll-ups? Roll-ups is a kind of a candy. You know about it? You know about it. It's a kind of a candy that is advertised as a candy that is fruit-based. What can be healthier than fruit-based candy? However, it contains a huge amount of sugar. It contains dehydrogenated palm oil, and it contains flavor enhancers. All of them are very bad for you. So I'll give you an example of what our Ministry of Health did. This is, in Israel, mostly advertised on TikTok. So we recruited TikTok opinion leaders in the ages that are relevant, from 8 years old to 16 years old. And we launched a campaign on TikTok. Within 7 days of launching the campaign, there were 4 million views of this campaign. Just to let you know, Israel has only 10 million population, even less than that. So this was a huge success. This is what we call harnessing digital for patient care. And obviously regarding healthcare services, home care and hospital at home, safety at home is not, home is the safest place. No, not really. The continuum from patient care at hospital to the community. We need to use digital to enhance preventive medicine, to enhance patient experience, to prevent inequalities like geographical, financial, literacy. And one of the more important things that we are using family members and healthcare team members, we need to educate them. This is certainly an issue. So I think that if we harness digital to patient care, this, what is in the next slide, is going to be a never event very soon. Thank you very much.
Thank you very much, Shaul. You have given us a different perspective, including patient perspectives, which are also very important on the matter. I think we closed our presentations, but we need to move to questions or comments from our audience. I don't know if there are any questions from the online participants. Anybody? Well, if you allow me, I have one question for Chris. Chris, you mentioned clinical and technical governance as key factors for transformation strategies, for digitalization enforcement. I would like that you elaborate further on the technical governance, if you may. Thank you.
So this is one of the concepts that was embedded in the digital mental health standards that Australia launched in 2020. The concept of clinical governance has been around for a long time, as we know. That's used across many countries. But this idea of technical governance is thinking about the risks to using technology for the purposes of delivering healthcare. So what are the implications for things like privacy, for information security, and also for the use and the transparency of use of data? So those concepts are embedded into the digital mental health standards that we developed. And you know, the risks associated with using technologies and using online services for patients is unfortunately enormous. We have big risks to privacy. We have you know, a number of access barriers, looking at things like digital literacy. So it was very important for us to consider not only the clinical components of how psychologists and psychiatrists deliver these types of tools and technology, but importantly, what are the technological factors, what are the technological risks that could potentially serve as being harmful to patients who are using them.
Thank you. Another question for Tino, if I may. Well, I'm quite fond of this sixth lens concerning the digital aspects which must be considered and to actually evaluate everything through data. I have a question. Actually, this is a concern. Is there any mechanism or any controlling methodology that is applied in order to somehow evaluate the comparability, transparency, accuracy, or reliability of data?
This is a tough question. In terms of indicators, for sure, you have standard indicators that are well adjusted and can be used for comparing. In terms of transparency, it touches the political scene, and we have heard different experience, the level of data protection in different countries, and how this can affect this data exchange. So this would change from country to country and also culturally. And for instance, in the case of secondary use, there have been many initiatives that have been blocked by these elements of data privacy and have deterred the progress on this sense. So we should look at country level and in terms of methodologies to check the levels of transparency. I'm not aware of, but probably there are.
Thank you. Thank you very much. And one last question for Shaul. You mentioned the, not barriers exactly, but probably the different conditions that may affect the effectiveness of telehealth or digital related services provision. So are there any ways to actually control these conditions, the interpersonal skills of the staff, or let us say prerequisites to apply this type of services?
In my opinion, the technology is ahead of the governments. So things are going on, and we, as a government of Israel, are chasing it. However, I think if we educate both the patients and the caregivers and balance between online and offline face-to-face visits, and making sure that we are aware of the obstacles to good and effective quality of care and safe care, I think we can advance our healthcare system.
Thank you very much, Shaul. Are there any other comments? Yes, please. May I have the microphone over there? Thank you.
Thank you all for the nice presentations. I've got a question for you, Chris, about the Choosing Wisely project. In the Netherlands, we've got a similar program with where we try to de-implement healthcare interventions that are not necessary, but we find it, or the experiences from the healthcare professionals are that they think if we de-implement something, we do nothing. They've got the feeling. So it's very hard to have them not do something anymore. What are your experiences in Australia with this project?
That's a really good question. I think the education component around it was extremely important. So presenting them with data and information about what the risks were to patient harm by doing ineffective treatments, ordering tests that weren't necessary, showing them the data and showing what the potential harms were extremely relevant to that, to trying to change the behaviour. You're absolutely right in saying that if you, try and walk back those things and try them to do the opposite of what they've been doing for a long time, that can be quite challenging to do. But presenting them with the facts, presenting them with the data and that information was instrumental in that behavioural change.
I think that we have reached already the closure of this session. Thank you very much for your attention, and also our dear speakers. Thank you.
Checking on the chat if there are any questions, comments. People online, please, just a reminder that you can participate and you can write on the chat if you have any questions, comments, contributions. And I think we will now move on to the next session. So I'm delighted to invite to the stage the president of the ODP, which is the, let's say, in general terms, as an abbreviation, the quality agency here in Greece is relatively new, like the WHO Athens Quality of Care Office. And therefore, I'm very grateful to Professor Daphne Katialidou for accepting to be with us for these 2 days, and also for kindly agreeing to share this session. Thank you very much. Floor is yours. Over to you. The red one.
I would like to thank you, Dr. Breda, for this wonderful opportunity that you provided to us all. Actually, to have the opportunity to get together and exchange and share, I think, common visions, common values, but also pathways, some of them common, some of them different, but to a journey for a common destination. And this is a health system that actually does whatever necessary to improve the care provided to the patients and be as responsive as it can be to the needs of the patients. I'm going to share a few information about this new organization that was established. Do you want me to get there? Thank you very much, and I can move on with this. So I will very briefly present to you ODP, which is the National Quality Assurance Organization in Greece. It was established only 2.5 years ago, on the end of the 2020. Before that, we must admit that in Greece there was no systematic framework for quality assurance and quality improvement. Either there was no reporting system of quality indicators, and I think this was brought up yesterday. However, after the establishment of ODP, it was a long way. We had to rush to work very hard to keep up with all the improvements done on the quality and the patient safety level. So, trying to answer to the question set by WHO, which is what are some best practices or some innovations that we try to adapt, I will start by saying that the first of that was that we actually adapted the international frameworks that were there, WHO, OECD, which actually adapt and expand the definition of quality. Instead of only talking about patient safety, effectiveness, and responsiveness to the needs of the patients, now to go beyond of that and actually engage the fundamental principles of equity, accessibility, efficiency. So we try to develop, and we worked on a threefold objective. First of all, to create a quality assurance and improvement framework. So we tried, and we are in the process of that, on developing standards, policies, procedures. But at the same time, we are actually educating and training health professionals to develop a culture of measuring and reporting quality indicators. These are all new to our health system, to adhere to mandatory procedures and actually follow the standard set. At the same time, we try to work on the principles of accessibility and equity. Therefore, we try through a data-driven strategic programming to ensure that each patient receives the right care at the right place, irrespective of the place they live. In Greece, we have geographic imbalances, so this was also for us a fundamental point. And of course, to bring patients in the center of the health system, which is rather paradox. We are talking about patients, but to a large extent, they are somehow invisible. So what we did, among the first actions we took, was to try to transform the system into a system that listens to the patient voice. So if I share very briefly some good practices, I will say that we started with a national strategy for quality assurance and patient safety. That was for us a roadmap on where we should move on, and the priorities identified by this national strategy actually give us the way beyond. Another good practice I would like to share is the development. We developed a tool for the on-site assessment. I'm sure you all have similar tools. However, the best practice here was the self-assessment phase. So before the group of experts of ODP actually visits the hospitals, hospitals take a 2-week notice, they take the same tool, they have training from ODP experts, and they self-assess their services. So it's a reflective process. They actually assess their own performance, and for us, it's a one step further towards clinical governance. The second good practice I may share, and I'm coming to the end, is the way they get the reports. So they don't just receive a report with what was found. A meeting is made in the hospital where experts from ODP, but also staff, managerial staff and health staff from the hospital actually work, comment, discuss the findings, and through a teamwork, we actually have a common roadmap and the way that we will work further. and we use a color code for what is quite altered to be changed, etc. At the same time, within 1 year, we had to develop indicators, the quality indicators that have been discussed so much, and we worked on what already have been discussed the previous day. So we do have indicators in place. We have effectiveness indicators, most mortality, readmissions, patient safety indicators. For example, a priority for us are the health-acquired infections. The position of the country is very low on that. So we have already 6 indicators about hospital-acquired infections. Staff safety indicators are also included. And of course, the so much discussed patient-centered indicators, the patient-reported experiences and the patient-reported outcomes. But before I come to that closing, I will have to say, and we are quite proud from a platform we are working on, because human resources and other characteristics of healthcare organizations are of paramount importance for quality. So for us, the staffing mix and the skills of the staffs are indicators that have to be taken into account and have actually information on a real-time basis. So yes, we are measuring PREMS and PROMs. We started. We have the first round. We are participating in the Paris project of OECD. We are getting now in the main survey. And I think that globally there is a shift, and we have to recognize it, towards value-based care. So PREMS and PROMs, the use of PREMS and PROMs will only be accelerating in the future. However, there are challenges. And I think I'm opening the floor to the next colleague who is going to refer to that. But embedding these indicators in everyday clinical practice is a challenge. The digital transformation that we heard in the previous session is a challenge. But I will also highlight the need for training for both patients, carers, and health professionals. However, I think that the greatest challenge is to think constantly out of the box. Each healthcare system to find ways, innovative ways, and we have to find grounds in rigorous science, hard work, but also networking. We can help each other, and I think this is a clear message from WHO Quality Office, and we are thankful for that, dear Professor João.
Thank you. Thank you very much for sharing this, in a way, detailed but short description of what ODP is and is doing. Also, like our office here, we're still in its infancy, but already breaking new ground and really with a very significant contribution to advancing these processes here in Greece. And if you allow me, one of the highlights, talking about collaboration and cooperation, working together in countries. Very recently, we as WHO facilitated a visit of a delegation from Albania, a group of people, and they are online, that work around quality. We implemented a sort of a twinning exercise with ODP. So this is something that we very much look forward to do more, to facilitate it, maybe bringing people together. Not that ones are more advanced than others, it's not the point. The point is really to learn from each other and to advance things all together. So this is, I think, a very nice way of working, looking forward and collaborating as well. As a network, but also on one-to-one, bilaterally, this is something that we would really be very keen to promote, to facilitate these alliances and these twinning exercises whenever they are deemed necessary. So with this, I hand over to you, and I will leave the stage so that you can facilitate the session. Thank you very much.
Thank you. We want to thank you for this close collaboration, despite the infancy stage at which we both are. I think a lot of work has been done by WHO Quality Office, and I think all the participating organizations. So I am now passing the floor to Dr. Walter Fonseca, Walter, I think the introduction has been made. I set the floor for you. He's going to talk to us about a new paradigm, value and right-based healthcare. It's the new endeavor. We discuss a lot about value-based care. Intermediate, there are many steps we have to take and many challenges we have to address. So please go ahead and give us a deep dive in this destination. Just to add that Dr. Walter Fonseca is an expert of WHO.
Thank you so much, colleagues. It's a great privilege to be here today speaking about a tricky subject, which is value and rights-based healthcare. But first of all, let me congratulate Dr. Daphne for the extraordinary vision for the agency here in Greece. Congrats. So, I will try to cover some of topics regarding first the current stage of quality of care, especially in the post-COVID-19 era. Also then going a bit deep into this concept of value-based healthcare and the touching points with quality of care as well. And then I have to try to answer this question, are we facing or not a new era for quality of care? So, yesterday, we heard about a word which is perma-crisis. Actually, healthcare systems are facing huge crises, and we can actually approach this crisis in three ways. First of all, we have a crisis of value. This means that we are facing an unsustainable growth in costs and also substantial wastes. And most important, we are having no link between the money spent and health outcomes. Secondly, we are facing a crisis of evidence because, as we just heard in the previous talks, we are facing an information overload that is almost impossible to handle with. And as we probably know, when we are ready to adopt and implement guidelines, they are, most of the cases, outdated, because the process of implementation is quite slow. And finally, we are also facing a crisis of purpose. And this is probably connected with the workforce shortages we are facing. It's not just about burnout, it's also about people that decided to work in the health sector are facing a crisis of purpose. They are not finding the reasons why they are there. But at the same time, quality of care is again on the top of health policy agendas. And this is a huge opportunity for all of us in this European network and also for the WHO office in Athens. And why this is happening? This is happening because, of course, quality of care is a need for achieve universal health coverage. Also because it can promote trust in healthcare systems and authorities. Also because it can actually lead a digital transformation towards the public good, promoting that digital tools are actually fit to people's expectations and needs. And finally, quality of care can strengthen the workers' resilience. However, we also must recognize that probably quality of care in the current approach is not enough. And it's not enough. Why? Because it's still too much focused on processes compliance and on service provision. And it is a fact, and there is lots of data showing that besides quality improvement efforts, the results and outcomes in health vary a lot, even within countries, regions, and so forth. So it means that although we are doing a great job in quality of care processes and implementations, we are still facing huge differences between results, between populations, between patients, between countries, between regions. And in that case, we are not targeting health inequalities. So now the deep dive in some minutes on healthcare value and on value-based healthcare. So I would like to start by saying that value-based healthcare is not an economic concept. It is an healthcare approach. It is an healthcare approach to what? To recenter all the stakeholders around a common objective, which is provide the best outcomes that matters to patients for the money spent. So, from an healthcare perspective, a value-based healthcare is an approach that aligns, as I just said, all the stakeholders in the sector around a shared objective, which is increase and improve outcomes that matters to patients for the money spent, and how this approach can be actually adopted and implemented. So basically, of course, we need to have a policy framework, but also 4 dimensions are critical. One is, of course, the way the delivery of care is organized, and I will come back this a bit later. But also we need a digital infrastructure that needs to be robust. We, of course, need research, tools, benchmarking, but also payments. I will not enter to the payment side, but it's very interesting to know that some of the things we are now facing in healthcare sectors, such as care fragmentations, obstacles to innovation, even burnout of the workforce, are related to this classical way of fee-for-service payments. So we need also to improve quality of care, to take into account the way the health system is funded and is paid. So regarding the care provision, usually to approach a problem in a value-based healthcare manner, we need to follow 6 steps. First, we need to target a population segment. We need to assess the needs of that population to have a people-centered approach. We need to select evidence-based and feasible interventions. We need to use the key indicators, the ones that matters for patients, PROMs as an example. We need to measure based on a good quality data infrastructure, and of course, we need to play a bit with the payments and also to improve effectively the outcomes. However, the problem is we are not being successful in the way we are implementing value-based healthcare in a system perspective. We have very good examples in terms of pilot studies, clinics, some regions, some hospitals, some primary care facilities, but they are all fragmented and uneven. They are not sustainable. We are not getting there. We are not getting a system perspective implementation of this concept that, in terms of a concept, is a very good one. So there is this inflection point concept now, and now meaning 2022, to push a bit the value-based healthcare towards a system perspective. And in the moment, I need to start trying to answer this question. So let's go a bit back to the 3 classical dimensions of quality of care that we all know. And we have now this huge momentum because the 3 dimensions are quite solid. So we can start building up on top of this. So we all here in this audience know about safety, effectiveness, and people-centered care. And now, how can we actually use value-based healthcare? How can we actually push a bit quality of care towards a system perspective, not only a service provision approach? So first, we have a huge and new powerful tool. As we just heard, we have digital transformation, which is the present, not the future. And for the first time ever, we have the power to measure. We have the power to go further in terms of these dimensions of quality, to increase safety, effectiveness, and even people-centeredness care. At the same time, we have the concepts of value-based healthcare that are giving to quality of care frameworks a new realignment around value that matters to patients, pushing a bit quality not to focus merely on processes, but start focusing on results and results that matter. And also value-based healthcare has this very powerful message that is to align all the stakeholders around a common objective and not having payers with an interest, providers with other, patients with others, and so on. But my question now is, so the first part of the answer is yes, we can learn with value-based healthcare concepts for the quality of care frameworks. Yes, we have a very new and powerful tool that are changing the way we provide care, but is this enough? And I must say that probably to tackle and target health inequalities, the answer is no, it is not enough, because all these concepts are based on individual value, the value for a specific people that, a specific person that has a specific clinical condition. But now we are challenged by things that affect populations that are healthy, populations that are at risk, populations that are out of the system. And this, when it comes to human rights approach to healthcare system. So in order to achieve actually the universal health coverage, which is one of the sustainable objectives for the 2030 agenda of the United Nations, we need to push quality of care empowered by digital transformation and with the concepts of value-based healthcare, not to focus on the individual, just that, but to bring equity and specific interventions to decrease health inequalities. And here are the concepts that we all know: equity, integration, efficiency, and timeless. So we are talking about not just an individual value based on a quality and safety culture and value culture, but more importantly, a public health and social value based on a human rights culture. And this is being studied, it's very recent, so we are still under also our way of thinking on this, because as you probably are aware, the quintuple aim is exactly health equity. So going to the end of my intervention, I would like to, going back again, the 6 steps of value-based healthcare, to show in blue the things that we can do when we try to expand from a service to a system perspective, from an individual value to a public health and social value. So populations that are targets by interventions should not only be the ones that are sick. We need to target at-risk populations, disadvantaged, marginalized populations, populations that probably we are not aware of because they are not having access to the system, they are not touching with the workforce. Of course, when we are assessing the needs of population, we need to put their needs in terms of social and economic determinants. The indicators that are being selected need mandatorily to include the ones that matters to patients and the ones that can measure equity. And finally, in terms of the improved outcomes, in this way, we can actually foster universal health coverage. So to end, just 4 messages. One is to innovate on quality of care, be collaborative and more agile. I think we learned a lot during the COVID-19 pandemics, and it was very much related to the way we were able to collaborate and the way we were able to surpass some classical boundaries. So I think it was, or it will be, a pity if we just now come back to the old school procedures. Secondly, I think we can empower quality of care strategies through digital transformation, as we probably now believe. And we need urgently to push quality of care towards a system-wide perspective, focusing on measure outcomes that matters to patients and populations, and add a human rights layer to decrease health inequalities. Thank you very much for your attention.
we would like to thank you, Walter, for this very comprehensive lecture you just gave. And I think a lot of things may remain to discuss. But if I can just sum up the main messages, I think that you made it clear that universal health coverage without quality and without equity cannot go on a separate basis. So a lot of work we need to do to align these axes. But I think we are coming back with questions after I pass the floor to our colleague, the delegate from Bosnia and Herzegovina. I'm so sorry there is no name on the program, so please introduce yourself, and we are happy to have you with us.
So, hello everyone. Thank you to our dear hosts for invitation to speak today to you. My name is Vera Kerleta-Tuzovic, and I'm head of the Department for Standardization, External Assessment and Education of our Federal Quality Agency. I will try today to present you what we as agency did in Federation of Bosnia and Herzegovina, and I will connect the work to the theme of new paradigm, right value-based healthcare. Agency for Healthcare Quality and Accreditation in Federation of Bosnia and Herzegovina is main federal point for defining, measurement, collection, analysis, and improvement of standards for clinical praxis and management of services. We are also responsible for awarding accreditations and certifications for healthcare institutions in private as well in public sector. We are responsible for developing, collecting, and analyzing healthcare indicators provided from the institutions. And we are also responsible for education of healthcare professionals, such as basic education in quality, education of our external assessors, facilitators, quality coordinators. And we are also proud to be included as part of specialization for family doctors. And we also do some tailor-made educations. The agency itself, I would say we are only 18 years old, but now when I see that there are some younger agency, I will say we are just enough old. Through these 18 years, we have developed and revised several times our different set of standards. And at the end, we have 16 sets of standards, not only for hospitals, for primary healthcare, but also for pharmacies, for centers for mental health on primary level, also for early child growth and development standards. Then some specialized standards such as baby-friendly hospital. And we have specialized standards, ISOSI, we named them ISOSI. Those are inclusive standards for persons with disabilities. We have a well-established system for certification and accreditation, starting with education, facilitation of the institutions, external assessment. We have a broad network of associates. We have quality coordinators in each healthcare institution, and all the institutions have quality boards. We have also, within our work, developed several guidelines for quality improvement of healthcare provision, such as those for coordinators, those for top management of the healthcare institution, for risk assessment, and external assessors. So, as you already heard, we have two different processes. That is something that differentiates us from most of you, I think. We have certification that is mandatory by law of healthcare, and it considers only the safety of the patients, safety of the health workers, safety of equipment used, and facilities as well. And built on that, we have also accreditation that is voluntary for all healthcare institutions, and it considers only a quality. So we had a long and a hard way, and now after these 18 years, we are merely half the way to have all the healthcare institutions either certified or accredited, though the certification is mandatory. This is example how our standards look like. They had various shapes until 10 years ago, and in the last 10 years, we have standardized the frame for our standards, so all the standards look the same. You can see in the first line the standard itself, and then later on you see the criteria that are identified by numbers, and also they have a letter S or an A, meaning those are safety or accreditation criteria. So these are our experiences to have a successful process of certification or accreditation for the healthcare institutions. First of all, dedication of top management of the healthcare institution is the most important thing. When you have top management on your side, they can motivate the personnel. They can motivate them by competitive aspect, financial aspect, or any other aspect. Different institutions require different time for preparation and external assessment, successful external assessment. And the last, but not the least, it's the facilitation. It is peer review approach of the colleagues who already passed the whole process, and the facilitation we see as a positive pressure to the colleagues to finish the job they have started. So, a new paradigm. It's actually the concept that focuses on delivering healthcare services that are patient-centered and value-based, rather than being purely profit-driven. What we have already done is that in all our standards, we have chapters that are dedicated to patient rights. Right to choose female or male doctor, right to accept or refuse some intervention. So various right questions. We included patients in the standards definition and development. We developed inclusive standards for persons with disabilities exactly for the point that all patients, all people should have equal rights to access the healthcare. We have mandatory patient satisfaction questionnaires in our standards. So all institutions that have successfully passed the process, they question their patients about satisfaction with the service, with all other aspects. Not only that they ask the patients, but they analyze the questionnaires, and they report those results to us, as well as action plan based upon those results. We have also mandatory yearly reporting from each healthcare institution from their quality board with various parts of the report. So by this approach, ACAS, our agency, prioritized the patient's right to receive high quality care that would align their values, preferences, and needs. But there is so much to do. I said that we are merely on the 50% coverage. We would like to have more than 80% coverage of certified and accredited institutions. We could build additional indicators on value-based healthcare for the institutions so that they can report to us what are the results of those indicators yearly. We could build in additional questions for value-based healthcare for the patients so that they have more outcomes to report. And also the mandatory report that I have mentioned that every healthcare institution reports to us, we could give their mandatory part on right and value-based healthcare. Thank you for your attention. I'm here for all your questions.
Thank you very much. Vera, if you want to sit with us in case we have questions, we want to thank you so much for this presentation. And just let me take the opportunity to say that experience, I think, from all the organizations that are working hard to establish a quality assurance and quality improvement framework are similar. I have to underline the fact that the road is hard, difficult, and long. However, I think that the improvement made during the last decade is quite important. And I am now passing to the next presenter. I think today and yesterday, 1 out of 10 words maybe is patients. And I think that is a very positive meaning. The heart of all things, the heart of the health systems are the patients. The health systems are there for patients. So I think bringing them into the center of the system is something that needs to be done, and I think a lot of work is there. So I will pass the microphone to Mrs. Claudia Luardi. I'm sorry if it's not pronounced well, but Claudia, I'm sure you will correct it, who is the head of policy representing the European Patient Forum. So the mic is yours.
Thank you very much, and no, you pronounced it perfectly, so no problem in that front. I will share my screen. I hope you can see it. Okay. So thank you very much for the invitation to present the important role of patients in improving quality of care and patient safety at this important meeting. So just a couple of words about EPF, the European Patients Forum that I represent today. EPF is an independent, non-governmental, non-profit umbrella organization of patient organizations across Europe and across disease areas. It was established in 2003 and we're based in Brussels. And we have about 79 patient member organizations and associate members that represent EU-level disease-specific organizations as well as national-level non-disease-specific organizations.
Claudia, I'm sorry to interrupt, but we are not actually seeing your presentation. I don't know if you have shared it with us.
Sorry about that. Okay. Do you see it now?
Yes, thank you very much. You can say it now.
Okay, sorry about that. Thank you. So as I was mentioning, patient safety and quality of care are at the heart of our work. They've been priorities for EPF for a long time. We've been involved in several projects as well on this front. And we believe, that patient safety and quality of care are really fundamental rights for patients. And we want to promote that vision. So why is it important to involve patients in improving quality? So patients are by necessity frequent and long-term users of healthcare services, and they have a unique perception of healthcare, and they have a lived experience of the care process, which is really important in order to have a full vision, of what high-quality healthcare means. Similarly, patients are a source of information about failures and gaps in the system, and in that sense, their feedback is very important to inform the process. So patient-centeredness is a core component of quality care, and we still believe, that patients are sometimes an untapped resource in improving the quality of healthcare, and we want that to change. So I've included here just a reference to our charter on patient empowerment, which encapsulates the cardinal rules of what patient empowerment is and what really matters to patients, and of course, including patients' experience as a vital measure of healthcare quality is part of this charter, as well as participation in evaluation and co-designing healthcare services so they work better for everyone. So as I mentioned, we were involved in a number of projects, and one of them was a survey of patient representatives and what they think about quality in healthcare. So in 2016, we did this survey and we published a position paper in 2017, which is largely based on the results of this survey as well as other related work. And our objective here was to compare what mattered to patients and how patients would define quality of care compared to the definitions that existed at the time of the WHO, as well as of the European Commission's expert panel on effective ways of investing in health. And as you see, some obviously there are some overlaps, but there was also quite a specific perspective, that patients brought, and certain things that they emphasized in particular. So, for example, the accessibility. So patients really emphasized the need for timely and accurate diagnosis with prompt follow-up treatment, not having to wait too long for either diagnosis or treatment. The fact that care should be tailored and adapted to individual needs and preferences. The first question that they want to hear is what matters to you. Emphasis as well on collaboration, that there is really a dialogue between patients and professionals, and that we try to find solutions together, that professionals take time to listen and help this co-decision. And then, of course, a strong emphasis on trust in the safety and quality of care that should be a given in a healthcare system, in a high-quality healthcare system. Other aspects as well were not necessarily covered by the definitions that we examined. So, for example, when we go into quite a lot of granularity, but a need for patients to minimize the bureaucracy to ensure that the processes are simple and easy to navigate. Family involvement as well, especially for vulnerable patients. Patients want to feel respected and respect of their choices. And the emphasis as well on integrated and coordinated care. So, for example, having the same doctor or one healthcare professional who knows your history and can follow you through the process is also something that was mentioned as an indicator of high quality care. So all of this to say, that the patients have that unique perspective, and that it is important to involve them in the process as you define indicators and as you evaluate quality of care. And that feedback, it's important. Patients want to make sure as well that their feedback is heard and that it's taken into account, and that it can improve care for others moving forward. So this is why we really promote this building and implementation of a patient-centered culture focused on continuous improvement. So from the research and evidence gathering, so ensuring that patients are part of identifying the relevant questions and the design of the evidence gathering, and to the knowledge, making sure that guidelines include all the relevant evidence, that patient recommendations are also heard and included, that the language is accessible, and that they are disseminated widely. Patient-centered care performance as well, making sure that patients are involved in service design, that services are health literacy friendly, and really promoting that collaboration with providers and the dialogue. And then finally, patient-centered change, so making sure that as part of the evaluation, patients are involved. So just to note on that, related to quality indicators, EPF participates in the OECD Paris initiative, which was launched in January 2017 in order to assess health system performance from the patient's perspective. And the aim is really to develop internationally comparable instruments to collect patient-reported health outcomes and patients' experience of care. So final words to conclude here. So the indicators for assessing the quality of healthcare should be defined also by patients themselves. They should not only be what providers assume is important for patients, but the patient's perspective really must be included. Patient experience is not the same as patient satisfaction. That means that the patient experience should be adopted as a key metric. And it's not just a box-ticking exercise. It must be meaningful, including qualitative, patient-centered measures. Patients' feedback should be actively encouraged, listened to, and acted upon. And just to note that only the patient sees the whole journey. So patients can identify gaps in provision, but also superfluous or unwanted services. They can help make healthcare more effective and efficient, and in that sense, they have that broad overview that is needed in order to build high quality care and to evaluate the quality of care. And of course, following up on the information that is collected and involving patient communities and advocates' expertise in the design and in the implementation. And a final word on information and health literacy, which are such important aspects of patient empowerment and involvement. Health literacy supports patients in becoming aware of their experience and role, further channeling their input into the daily experience. They can participate in shared decision-making concerning treatment, for example, and in that sense, health literacy is also a key part of this work on quality of healthcare. So that was just a broad overview. So thank you very much for your attention, and I'm available for any questions.
We would like to thank you, Claudia, for this perspective that you provided from the patient's side. I think what is important to see here is all the aspects missed so far. And this is just to say that there is a lot of work to be done yet. Yes, we are measuring. I think more or less most of the countries started measuring experiences, started measuring outcomes. The challenge here is, first of all, how do we use them? How do they affect everyday practice? How do they affect the decision-making and the policy level, the experiences? And what is the access of the results? I may say, today, maybe there is a bulk of information. Walter, you mentioned overload of information, and that's true in most of cases. There are cases that we have poverty in data, so poverty in information, and there are other cases where we have information, but we are, I think, too focused to protect data. So academia, experts, organizations actually do not have access, and they don't share data we need for the common good. Patients are also in this endeavor. So yes, we want the measurements, but we also need to know what should happen and how can we overcome the barriers and the challenges to embed them in our everyday practice, in our everyday decision-making procedure. We are beyond time, but I'm opening the floor to questions, maybe one or two questions I think we can address. So, is there any questions from the audience? I was too scared to say we are over time, but we do have a couple of minutes if there are points that you want to bring to the discussion. No? No questions. So in that case, I would like to thank very much all the three speakers. They gave us a very helpful insight, and definitely they opened the road to more discussions, more work that needs to be done in that field. So yes, we are heading, we're shifting towards value-based care, but we have a lot of challenges to address, and I think patients have a very, very important role in this and should be in every discussion made in every country by every international organization. So thank you very much for this very, very, I think, comprehensive session.
If you allow me, just a small announcement. The Athens Quality of Care Office initiated a podcast on quality. This podcast is led by our colleague Thanos Miloneros, which is sitting there. So if you want to engage with it, feel free to contact Thanos. And you have here, so the QR code. There's the first episode. He needed a guinea pig, and the guinea pig is me. So I did a very bad job, but the podcast is going to be good in the future. So if you like it, please engage. There will be communication about it. I think we received good feedback, actually, up until now. And it would be published periodically, so more or less once or twice a month. So stay tuned and feel free to engage and disseminate. Thank you very much. We have it only in English now, but maybe we should think about also other languages in the future. Thank you very much. Bon app. In 1 hour, we are back, okay? Thank you.
Vida pendek che Ξυπνήστε και κάντε τα όνειρά σας πραγματικότητα. Εμπνευστείτε και εμπνεύστε τον κόσμο γύρω σας. Όλα για την ομορφιά σε μία ιστοσελίδα. Δώρα, προσφορές και ελκυστικές τιμές. Βολική και γρήγορη παράδοση. Ανακαλύψτε τον κόσμο της ομορφιάς. Δημιουργήστε τη διάθεσή σας. Η ομορφιά δεν έχει όρια. Makeup.gr. Μία μοναδική επιλογή προϊόντων ομορφιάς.
Good afternoon. Because we had special requests to see if we can finish a little bit before the time we have in the program, we should not waste any time, and we will try to start over again. And it's my great pleasure to invite Angeliki Karaiscu to chair the next session. She's also a collaborator of the ODP, the quality agency here in Athens for Greece, and also very grateful for the collaboration you're having with our office. So over to you. Thank you.
Thank you a lot, Professor Joao. After our lunch break, we are moving on to the next session with the title, The Next Frontier on Health Science Education, Teaching and Learning. Thank you. Okay. Teaching and Learning for Quality and Patient Safety. Dear colleagues, we all know that education is a core element in everything we intend to accomplish in the field of patient safety and quality improvement. Of course, there are many key elements that can run education really effective, as effective as we want, in order to improve our processes and yield positive results. More than that, I think that education has another principal goal to change behaviors, healthcare workers' behaviors, culture, totally the operation of the organization, to change the structure, the system. So now I would like to kindly invite Mr. Martins, Professor Martins, who is an expert, collaborating with WHO Athens Quality of Care and Patient Safety Office, to share his experience. And his knowledge. Thank you.
Thank you very much, Angeliki. So I'll present to you some work that me, Juliana, and Joao have been working on. See if the slides will come up. Yeah, there they are. Basically, the question is innovation in teaching, and what. So I would like to acknowledge the work that has been done mostly by Juliana. She's been the one reviewing literature and coming up with the main substance of the evidence. The idea on looking at innovation in education and education on innovation for quality resulted from ongoing work. And basically the challenges of healthcare workforce have been yesterday highlighted. Lack of health professionals, post-pandemic exhaustion, I would say, and changing expectations. Also, we have seen yesterday, today, different examples of digital innovation, social innovation, workflows, value-based, I mean, all sorts of innovations. But at the end of the day, this has to come down to value of professional work. And interestingly, professionals' satisfaction and commitment to work has been associated by previous researchers to innovation. So the concept of quality of care is evolving one, in a way, alongside changes brought by innovation. But our starting point is that healthcare workforce needs to be able to promote quality of care using innovation, but they also need to be invited to be co-creators of innovations. And this is very important, not just use the innovation. So Innovation itself and innovative capacity has been recognized as one of the main competencies by different entities that are worried with graduate medical education or healthcare education. You see some examples here that we have identified, have public statements on the importance of educating health professionals on quality. However, medical education, for example, has a recognized reticence to change. Medical schools don't change that often. There are scattered efforts on health professionals' undergraduate training for quality. There's lack of innovative approaches in such education. So what we decided to look for in the literature is not only if medical, nursing, and pharmacy schools educate their students on quality of care, but how they do it, and if they use innovative approaches on that education. And as you can see, after screening a lot of studies, we didn't get a lot of them. So these 11 studies, they are our best attempt to find this information. So the first conclusion from our work so far is that there's actually very low evidence, published reports, published studies of schools using innovative approaches to teach quality of care. Well, actually, to teach quality of care itself, whether it's an old way of teaching or a new way of teaching. But we were looking at the new ways of teaching. This is what we really want to promote. So most learners had a positive evaluation, however, of their quality innovation curriculum, quality improvement curriculum. Studies and methodologies were described as frequently with poor rigor, and there was no comparison between different teaching methods. So when the paper reports a new teaching method, new teaching approach, an innovative teaching method on quality, they rarely showed any evidence that it was beneficial or not. But at least there was an attempt to innovate on how we educate healthcare workforce on quality. Quality of care and quality improvement were both differently used in papers. So there's a problem of, in a way, a little bit of a lack of knowledge in these authors, to the point that they refer to quality of care or quality improvement almost as if it's exactly the same thing, which becomes a problem because, of course, in this room, we know it's not exactly the same thing. And so we don't really know if these students were being taught on quality of care in general, or if they were specifically taught on quality improvement. Most studies were focused on undergraduate and early stages of training. The concept of innovation itself is scarcely mentioned. So, I mean, these are just a few examples. I'm not going to go into detail. Curricular innovation for quality and safety certification in a graduate program. This is a paper from the US. Engaging trainees in performance improvement projects. So there's different examples. This one, for example, we found interesting because they were trying to bring together interdisciplinary teams that included medical students, faculty people, residents, and staff, which, when you actually think about it, is very innovative, because most schools, I mean, I teach in a medical school, and some of you, of course, teach in different health professional schools. It's not very common that you put students, teachers, so faculty, residents, and staff, for example, of hospitals, in a multidisciplinary team to learn. This is actually not common at all. So it's very good that that we come up with this type of papers and promote this type of education. Using tools like online courses, quiz-based reinforcement systems have been proven to be effective. So reinforcement systems to reinforce learners' experience and so reiterate the ideas we want to educate. Again, another paper from California. Using MOOCs to contribute to improving healthcare capacity worldwide is very important. We have a problem of disseminating knowledge. So, for example, in this case, it was a Coursera MOOC on Take the Lead on healthcare quality improvement, which means that there is material out there. So schools can use existing materials, and often this is innovative enough that you don't have to go out and create new content. You can use content that has been produced by other schools, by other organizations. And again, for example, in this one, jumpstarting faculty development in quality improvement in patient safety education. So in this case, using a teams-based approach to improve the knowledge of the faculty, of the professors, so that they then can teach better and teach these topics to their students. Finally, using the same framework that I presented to you yesterday, potentially disruptive or radical, we are saying that, what would be a potentially disruptive approach in innovation in education for quality? It would mean that a school has a new pedagogical approach or experience, even including a new education business model, but not necessarily using new technology. So maybe they're teaching in a classroom, same old classroom, but they have a new pedagogical approach or a new experience. This would be considered potentially disruptive. A radical approach would be a visible effort to create new technology or methodology to educate differently the students. And of course, architectural innovation that you can mix both. When we tried to group these papers, these 11 papers into this matrix, we found ourselves with most of the papers landing on routine or incremental education. So most of the quality education, quality of care education efforts in schools is either not reported with low levels of innovation, or reported minimally with some disruptive or radical, let's call it this way, touches. So in conclusion, the main challenges are we need to build capacity in faculty. We perhaps need to think about accreditation standards between quality agencies, some of which are in the room here, and higher education associations or higher education groups. So for example, many countries have the boards of all the medical school deans or all the nursing school deans, and perhaps one day in some countries, you could have an interesting conversation between the quality of care agency and the deans of medical schools, the deans of nursing schools, and really ask them two simple questions. Do you teach quality of care? How do you do that? Can we help? And lastly, and not the least, can we accredit that process of education to make sure it is content correct? So I explained the difference between concepts is often not clear in the ones that are doing the education, which is an issue, but also, are you using innovative approaches? And why is this important? Because we cannot teach, I'm sorry to say what I'm going to say, it's my last sentence in this meeting, we cannot teach this important topic in a boring way. The last thing you want is to talk about quality of care to the future doctors and nurses and pharmacists and every other healthcare professional, and they get bored in the lecture. And 10 years later, when they are practicing doctor or nurse, and they come across a survey organized by the quality of care unit, their memory of the word quality of care is this boring lecture that they got in medical school. We have to avoid this. It has to be an innovative approach that is fun and engaging, but of course, pedagogical. Thank you very much.
Thank you very much for your presentation. Of course, we're going after the next speaker to discuss some more things, Mr. Martins. So I would like to kindly ask to invite for his speech Damir Ivakovic, expert from Public Health Institute from Amsterdam.
With this, you I have no slides. Okay. Yeah, I don't have any slides. So yeah, okay. Thanks. Thank you, Dr. Martinez, for a very interesting presentation and an overview of your summary work of the education on quality and safety. And I'll maybe just briefly then reflect on your overview and my experience of working as a public health professional, but also within different professional networks of public health physicians, but not only physicians, practitioners. And I completely agree with your last point that the teaching, the learning, academic, non-academic, formal and non-formal quality and safety should not be boring. So I agree that we should understand the motivation and agency or learning preferences of students. And most of the literature basically shows and practice that this should be done in a real-world setting. So this kind of teaching shouldn't be theoretical, it should be done in a real-world setting. Also the use of, you mentioned innovation, different types of innovation, the use of different tools. So a lot of also research and implementation that I did on tools was that use of different, and sorry to say this, business intelligence tools that are used in, because often this has a kind of connotation of more industrial approach to quality improvement or in general continuous improvement. Use of tools such as control charts or dashboards when talking about quality and safety is a great way of getting not only students but healthcare professionals involved with quality of care improvement strategies. So the work, for instance, that I did with nurses and mid-level managerial staff in hospitals showed that the use of such tools was really beneficial for starting the discussion within organizations on quality. So being able to show and visualize results was a good way of starting the discussion. So basically, maybe just to wrap up this brief reflection, it is that the formal and non-formal teaching of healthcare professionals, not only medical students, on quality and safety should be done in a real-world setting, should focus on continuous improvement rather than blaming and shaming. This is how this is often perceived. Should focus on building a sense of ownership when talking about quality improvement. Also, potentially a concept of second victim could be introduced. So healthcare professionals that have been involved in a medical error, not to normalize medical errors, but also not to perpetuate trauma and kind of suffering in silence. And happy to discuss further. Thank you.
Thank you, Lud, for your input. Are there any comments or questions for our speakers? Or any inputs? Yes, please. Greece.
Yes, congratulations for your lectures. I want to ask you, what about the use of stimulators in teaching, especially the personnel in the hospitals, about all the infection control and how to put central lines and all this?
So we didn't review on that specifically. There's a lot of publication on simulation, mostly, almost always focusing on patient safety and a lot on communication issues, for example, in teamwork. I think it's very useful. My personal experience, for example, I run a course in a medical school where we use simulation not to teach clinical procedures, but to teach communication skills and leadership skills. But I mean, you can teach all sorts of things. I think one of the big challenges is that real, advanced simulation with these robots is quite costly. And what we see is that many times medical schools, nursing schools, they have these simulators in rooms, but they didn't want to spend maybe $500,000. I know it's a lot of money, but $500,000 more to have what we call mobile simulators. Mobile simulators, you can actually put them on a bed in a hospital.
And the big difference is that you can, the environment is much more real. And the students or even acting doctors and nurses can be invited to do a simulation exercise in the ward using the real ward equipment and all of that. And I think this means that hospitals, which normally are run either by public or private ministries of health, and universities, which are almost always run by the ministries of education, they need to talk together. Because sometimes in many cities in Europe, there are simulators that are not being used in the morning in the Faculty of Medicine, and in the other side of the building, there is a hospital where if you have them, you could do really good simulation. So it's the first thing I would recommend is do not buy more simulators, but start looking at where are the equipments. The other idea on simulation is digital simulation. So virtual reality and metaverse-related technologies. There's a lot of material already for nurses, for example, also something for doctors. And this is also quite interesting.
And also for the people, I think they can teach, they teach CPR with simulators and how to use defibrillators. I think it's interesting in this and can help also in safety.
Yeah, definitely. I mean, one of the biggest take-homes that I want to highlight is the underused equipment. In most countries, this is a very common problem. We have spent millions on the equipment, and either because we don't train the faculty or the people in the hospitals, or because they're not really mobile, or there's this stupid barrier like, oh, we use it for medical students, but if it's a resident, it has to be the hospital. Well, just make a protocol and allow the residents to move to the other building and use the simulators in the afternoon, in the evening, maybe in the middle of the night, whatever.
Any other question? Yes, Ms.
So this is very interesting. We are discussing the new frontiers in health sciences education. And I just want to reiterate that in the Global Patient Safety Action Plan, the strategic objective 5 relates to education and training of health professionals, inspiring the future health workforce, developing competencies, as well as also ensuring their safety. So in this discussion, I think I just want to mention that already there's an existing patient safety curriculum guide for multi-professionals, which WHO developed in 2011. And we are currently in the process of creating an interprofessional education version as well, because that is the new frontier. Also, as you mentioned briefly about interprofessional education. So we have already been working with quite a few centers around the world for developing interprofessional edition of patient safety curriculum. It's in a modular fashion. So the first module which is coming up is on medication safety curriculum, which will be launched later this year. And it's how we bring together different specialities and train health workers on medication safety. So that's one of the examples, but we'll be developing it for other areas as well. So they are altogether about 11 topics which we have identified, and we are bringing standalone modules for interprofessional education. Medical simulation, which you mentioned, is a very important aspect as well. I have myself visited quite a few very good medical simulation centers, one in Oman, one in Saudi Arabia, one in Singapore. I was there recently. And we actually are also organizing a training of trainers, hopefully later this year in Singapore, where we'll be providing a visit to the center. And most of these exercises they do, as you mentioned, about patient safety. So they create scenarios where a patient is being harmed in a very complex environment, and how do those residents who are managing the patient, they manage this complex situation and avoid this adverse event to happen. So extremely interesting. Of course, it's cost intensive, but I think as WHO, we could, and we can discuss with Joao how we can actually create opportunities for cross-learning through study tours maybe, or through also training of trainers, some visits to these centers. Of course, they are not very easy to set up, but those which are existing are involved in providing training programs. And in your research, I wanted to mention, Dr. Martin, that we also actually published a paper on implementation of patient safety curriculum guide globally. And there were about 30 countries who responded in low and middle income country group, that what challenges they were facing in implementing this curriculum guide. And I think somehow the innovation which we're looking at should look into how do we address those challenges which were identified in implementing the curriculum. So we are really looking towards making this curriculum available to countries and creating enabling environments that they can take forward and implement it in day-to-day educational practices and courses. That how do we sort of, what challenges they faced in implementing and how do we address those challenges through innovation. So I think huge opportunities for cross-learning, for developing a future health workforce through innovation, but also looking into the issues of lower middle-income countries. Implementing simple curricula can be very, very difficult. So I think some sort of research would also be useful in that aspect. Yeah. Thank you.
Yeah. Just a quick comment. Thanks for the good intervention and wise advice. I would only add. So I agree with everything. I would only add that I think sometimes it's not that there isn't curricula plan documents. Of course, this is the first step, and thank God we have it already. My experience is that it's often about negotiating time in the curricula of schools, and that takes political effort. So this is why I'm stressing this at this audience. So as focal point, if you can raise the discussion to the ministerial level, and the ministerial level takes it to the education ministry level, this discussion at a highest level is necessary to open the doors. Not so much the resources in terms of the equipment, that's true, and low resource countries will have a struggle, a little bit more of a struggle. It's actually the worst resource, which is time. The biggest problem is time, is packed curricula. And the way to solve that argument, in my opinion, is the concept that you can teach patient safety and quality of care during the teaching of other disciplines, as long as the faculty, so your pneumologist teachers, your emergency doctors, faculty, are aware that in the middle of all the teaching they have to do on whatever, lung cancer, whatever, they have to have a small component of quality of care or patient safety within the teaching, and not have a separate block of hours. Although I think a separate block of hours is useful, but this is just a comment to you. I think the most difficult thing right now is finding the time and how to innovate on that. My experience tells me that students often find time. So if the material is not faculty dependent, so you don't depend on face-to-face teaching, sort of make it the resources available, make a game available, make something available to them, and self-learning stimulation, they will find the time. And I think they often do.
Yeah, absolutely. I think one point I want to mention that the medication safety curriculum which we are developing, we have given several options for countries to consider how you can implement it. It could be integrated into existing curricula, or it could be a standalone, could be a 1-week course for different audience for orientation, could be a longer course up to 6 months or 1 year. And even MSc courses are available in many countries. Quality and patient safety courses are available in several countries through, like Imperial College London is one of our partners in this, and they have a up-running course, and quite a few other institutes also have courses for 1 year or 2 years, diplomas and degree courses as well. So different setups will use it differently, but in the materials we are developing, the curriculum guide for medication safety as of now, we are giving different options how countries could implement the curricula. And I think it's not only the political will, but also the sensitization of the deans of, as you mentioned yourself, deans of universities and medical colleges. And in this direction, we are working very closely with our health workforce department, and we are going to create a network of educational institutions and councils, those who are the regulator for education, for medical and nursing education and pharmacy education. So we're in the process of setting up a network, a virtual network, where the academic institutions, the universities, the deans and principals, and those who are working in the academics and research institutes can share their experience of how to implement these curricula. These are newer areas. Patient safety and quality are newer areas in terms of training. It's still in infancy stages in many countries. So I think creating this educational councils network will be a good opportunity again for sharing of experiences in real time. Thank you.
Sorry.
Thank you.
Okay, maybe
Yes,
just add conceptually a bit on the learnings on educational quality and safety. I have a feeling that often, or most often, we talk about learning about quality and safety from good practices, from best practices, and that the notion of mistakes is then put in the category of blaming and shaming. There's something that started in the Netherlands in the banking industry, in fact, and it's ended up being a so-called Institute of Brilliant Failures, where failures and mistakes are being analyzed and typologized. And I would like to know if maybe someone has an example or a practice or a bad practice or learning from failures. How they define brilliant failures there is a failure that we learn from and hopefully do not repeat. So maybe if anyone wants to reflect on that.
Thank you very much. Is there any other comment? Yes, Professor João.
Just to stress on what Damit just said, because I mean, failure is the central concept of agile ways of working. And you know, agile is very much in fashion. There's many public organizations across the world looking into agile ways of working. It's not only what, for example, Netflix or Spotify use to develop their own products, or some, let's say, high-tech companies to develop apps. This has been applied, again, also in the bank industry, and it's really important that we accept and understand failure in everything we do. And I think that we as health professionals, we are not raised and trained to deal well with that concept of failure, which is, you said it, it's common sense to say that it's a learning opportunity. But as we look at innovations, let's also accept that many of these innovations, they are going to fail. And it's this part of the natural history of all these processes. So just to put a tone on the issue of failure as a great thing to work in a more agile way in public institutions. Thank you.
Thank you, Mr. Breda. Any other question? It's an opportunity to have this expert with us. If you want to comment something else. Okay, so to sum up, the conclusion of this table is that we have, with new strategies, built new healthcare professionals earlier in their institutions. Okay, thank you very much.
Thank you. We will move to next section of our meeting today, and I'm delighted to ask our colleague, while Tino prepares to chair the next and final section in terms of discussing some next steps and your expectations for the future, where we will go from here. I'm delighted to ask Suzanne Carai, which is our colleague now online, and she will be delivering a presentation on the WHO Pocketbook for primary health care for children and adolescents. Suzanne, I can see you are there, And I'm sure you're very excited to deliver this presentation of your pocketbook. So here you go. Floor is yours.
Thank you so much, Joao. Can you hear me well?
Very well.
Thank you. Would you be able to put up the slides?
We will try.
In the meantime, let me just start by saying good afternoon. And I hope yesterday you were actually promised a couple of copies of the pocketbook. Did you actually get some?
Of course. And there are
Very
more
good.
extra outside.
Very good, very good.
Slides are
Thank
coming up.
you.
Just
I will now walk you through the WHO Pocketbook of Primary Healthcare for Children and Adolescents as an example of many of what was discussed. I will not focus so much on the clinical aspects, but more on how the book operationalizes improvement of quality of care and patient safety. Next slide, please.
the first slide of the presentation, please. The first one after this one. It's work in progress, Suzanne. Bear with us. It's coming.
Okay, excellent. Okay, next slide, please.
Here you go.
Thank you.
We are
Can you hear me? Yes. Okay. So what was the rationale for the pocketbook? So the world agrees actually that primary healthcare is the most inclusive, effective, and efficient approach to promoting health for all. Yet what it exactly entails is less clear. And we know from some of our work with countries that children and adolescents do not always receive the care they need. In fact, there is considerable misdiagnosis and over-hospitalization, misuse of antibiotics, over-medicalization, and lack of health promotion. And many of these things, I don't need to tell you, have inherent safety concerns that need not be. It also leads to preventable mortality, morbidity, and disability. And there are many reasons for that, but one is certainly that primary healthcare providers do not always have the knowledge and resources to provide care that is evidence-based and in the best interest of the child. And member states actually requested WHO to summarize evidence-based comprehensive primary healthcare guidelines for children and adolescents that would be applicable across the WHO European region. Which means that for some countries, this little book will mean that they have to up their game at the primary healthcare level, so that they will have to staff the facilities better and put more equipment and tests in the primary healthcare facilities, but we wanted on purpose that these are the standards that are applicable across the region. And so one of the very first actions of the newly established WHO Athens Office for Quality of Care and Patient Safety last year was actually to launch the pocketbook for primary healthcare for children and adolescents. Next slide, please. I just said that we know from our work with countries that children often are hospitalized unnecessarily. And I would like to ask you all to reflect for maybe 5 to 10 seconds on these questions. How big is the variation actually across the countries? So across all countries of the WHO European region, what is the variation in the rates of hospitalization rates of children under 5 years of age? Are they more or less the same, around 2 times? Do they vary by 10 times or by 20 times? And here you already see the answer. The correct answer is 20 times. We asked this question several times. Usually people think more around 2 or 10. So there's quite a large variation. And this is probably not only due to differences in prevalence of disease, but also in practice. Next slide, please. Indeed, we asked countries to report the hospitalization rates of children under 5 per 1,000 children. And here you can see actually that there's really quite a large variation. So why do we think it's important? Again, I will not have to tell you, somebody said earlier, the hospital can be a dangerous place. So if you can, you should stay out of it. So there's safety concerns, there's risk of nosocomial infection and iatrogenic injuries. In addition, children are often separated from their parents, which can lead to detrimental effects on child development and mental health. And last but not least, it is also a financial burden to family and the health system, as care can be cheaper, provided closer to the families, for both the system and the families. There are 2 papers that look more in depth in 2 countries that actually really have taken the lead in reviewing their hospitalization rates and polypharmacy practices, Tajikistan and Romania, and very much with a focus on a positive outlook. So how can we strengthen primary health care to avoid unnecessary hospitalizations? Next slide, please. So how can the pocketbook actually help in doing that? So it is the target audience. It is aimed at everybody who provides primary care to children and adolescents from 0 to 18 years old. So it can be doctors or nurses or other healthcare practitioners that are actually responsible for the care. It is, as I already said, applicable across the WHO region. It is very much evidence-based, where whenever possible, it is based on the already existing guidelines. For some of the clinical presentations where there were no WHO guidelines available, we used other evidence-based guidelines that were developed in a similar grading process, like WHO guidelines. And it's supposed to be a practical pocket-sized job aid that can be carried around during daily work. Next slide, please. So what is in there? There's information on diagnosis, treatment, and management of common conditions and presenting complaints. So it's very much structured around the complaint, but it also includes rarer conditions that are important to diagnose early in the primary healthcare setting. It stresses very much what is safe to manage at the primary healthcare level, but also when to refer. It focuses a lot on coordination. So we also included conditions that are usually managed by specialists to enable the primary healthcare provider to fulfill their coordination role. And it also has a strong focus on health promotion and disease prevention, vaccination, screening tests, promotion of early childhood development, and many counseling messages, which actually takes parents and children on board in their care. Next slide, please. So here you see the table of content. I will not go, as said, very much in depth for each chapter. I left the slides in as they will be shared with you. So if you want to review them, they're all there. I will skip over the next 2-3 slides. Please, next slide. It's just the table of content. The chapter 1 and 2 are short chapters setting the standards for primary health care and reviewing diagnostic approaches, different well child and problem visits. It also focuses on infection prevention and control, how to organize your practice. Here you also see the Ukrainian translation. We are very proud that that is already available online. Next slide, please. Then chapter 3 gives information on how to monitor children across the life course, to actually identify problems early on. Next slide, please. Health promotion, I already managed. This is very much taking the patients on board to their counseling blocks, as you can see. Next slide, please. You can see here we have 42 of these boxes that can be easily photographed or copied out that provide important information to parents or the older child on what to remember after the visit with the doctor. We also have do nots. So again, for safety concerns, do not give prophylactic anticonvulsant therapy, for example, to prevent febrile seizures, or do not give ibuprofen to children with gastrointestinal bleeding. But we also have red flags. So when you need to be really careful and refer the child because it's not safe to manage them in the primary healthcare setting. Or alerts like morphine can cause respiratory depression, monitor carefully. So these are only examples, but you see the designs and they are repeated throughout the book to alert the primary healthcare provider. So these important concerns. Next slide, please. The chapter on newborn health focuses very much on normal variations. So again, with the idea to not unnecessarily have to refer, but it also has the red flags I just mentioned. Next slide. Then the chapter 6 and 7 are the core chapters of the book. They're structured around presenting with specific complaints or symptoms. And again, here you see these examples. Do not give routinely antibiotics to a child with cough. But on the other hand, the red flags when to refer immediately to hospitals. Next slide. The book has very many visual features to explain procedures or symptoms, and it also makes it easy to orient yourself in the book. Next slide. Then chapter 7 are the specific diseases and conditions. Many of those will be managed by specialists. But again, the primary healthcare provider needs to coordinate this care. And for example, if more drugs that could have interactions are prescribed, they need to be aware of what is evidence-based management of that care. Next slide. We have a chapter specific for adolescent health, which is also new in the child health space that we have before I don't know how many of you are familiar with the IMCI guidelines that only focused on children under 5. We now have conditions and concerns included until the age of 18. So everything that is specific to adolescents can be found in this chapter. Next slide. And the last chapter is about emergency and trauma. We decided to put it at the end of the book because usually they are not luckily so frequent in the primary healthcare setting. However, the pages are pink, so they can be easily differentiated already from the outside. So if you have an emergency, you're able to quickly find the relevant pages. Next slide. And the main content of the emergency chapter is actually in the book flaps, so very prominent and easily to be found. Same for the emergency drugs and dosages of the drugs. They're in the book flaps. If you have to treat fast, they're easily accessible. Then we have a few annexes. I will only point to 2. They're the practical procedures, which explain some more frequent procedures, how they are done properly. Again, we focus also here on the do not for safety concerns. We also focus a lot on hand hygiene and infection prevention and control. Next slide. There are the growth charts as well. Next slide, please. And then very importantly, and I think that was mentioned also yesterday, we have a large annex on drug dosages. So all drugs that are mentioned in the book are reported here with dosages and formulations and doses according to body weight to minimize calculation errors. So you do not, the primary healthcare provider they do not have to calculate the doses. They can just go to the weight and then see what the dose should be. We have important notes also when, for example, drugs are contraindicated. There are very few drugs where the dosage has to be precisely calculated according to body weight, because they need to be dosed very accurately. We also spell this out here. Next slide. So just the outlook, we are also in the process of developing a pocketbook app, and here you see the landing page that will have alerts, reminders, and also a drug dosage calculators that will then even be easier than in the book, because you no longer will have to go through a long list and find the appropriate page, but you can insert the drug and the weight of the child, and it will automatically calculate the required dosage according to indication, and also give information on potential concerns or interactions. There's a translation to several languages underway. As said, Ukrainian was our first additional language next to English. Russian now is also available. You can find them at the links below. At the moment, ongoing are translations to Armenian, Italian, Greek, Kazakh, Portuguese, and some others. We encourage very much country-specific adaptations to account for differences in the health system already existing, well-child schedules, mainly use drug formulations, and so on. We support this technically. If countries want the WHO logo on it, then they need to be able to state the evidence for said changes, but we very much encourage the adaptations. I mentioned the mobile app, and we are also developing a training course for primary healthcare providers, which is both based on scenarios and is game-based. So it's hopefully going to be a lot of fun. So thank you very much for your attention, and we are very excited about this work. So if you're interested and would like to translate it or run the training course, we would love to hear from you. Thank you.
Thank you very much, Suzanne. We can all see the enthusiasm. And if I could reiterate just the 2 points that you refer, one on translation for other languages. We would love to support that process, and the workshops to support implementation. This is something that Martin and Suzanne and the team here are working on. So reach out. There's a lot around quality and patient safety there, obviously, is one of the areas where we are having really huge problems in the region. So we are there and we are here to support. Just let us know. Get in touch, particularly with Martin, and they will make sure that you get the response needed. So Suzanne, again, thanks very much, and enjoy. Good night there in the Philippines, and I hand over now for Tino to chair the next session. Thank you very much.
Thank you, Suzanne. Thank you, Joao. It's 3 o'clock. We want to finish a bit earlier than according to the agenda, but this is the last part of the 2 days meeting, and probably is the moment where we can take advantage of what we have heard during these 2 days and reflect on which could be the next steps according to your views and needs. So I would like to do an exercise that will help to elicit your views and opinions in a very practical way. I'm always defending that small groups are the best modality to discuss things. And when I was now looking at the amphitheater, I saw that there is some sort of natural clustering in the room. So I would suggest to keep this natural clustering and make small groups of 4, 5 people to discuss about what's next. Try to agree which are the 3 next steps that you would like to do as part of the focal point network in collaboration with the quality of care office. And just remind what we have heard during these 2 days about the status report, about the open initiative, the open quality initiative, about the patient safety progress, about the digital lens, about the value-based healthcare approach, the last session on health education. So not only think about areas of focus thematically, but also in terms of activities that you would think necessary to do as next steps. In the agenda, you will see that there are 2 questions that are in some way triggers for this discussion. One is, do we need a framework for quality of care and patient safety adapted to the European region? This a question to discuss, and also which sort of tools we could need to develop to support countries and to advance the agenda of quality of care and patient safety. So my suggestion, natural clusters, I see one group here, just nominate one representative to report back to the plenary. I would suggest here to create one group in the middle. Around Kyrgyzstan can be another group if Baklihan wants also to join the group. And here on the left, another one. Also, our colleagues from the office, feel free to form a group or just flock around the different groups. One pick person per group, and let's put 30 minutes of brainstorming about these 3 next steps for the focal point network. And then we come back, we report back, we open discussion, and we will be closing. Okay? Any question? You can also use the coffee area. Yeah. But try to do it in small groups, eh?